Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars organized in collaboration with the World Federation of Neurosurgical Societies, the WFNS, the Egyptian Society of Neurological Surgeons, and the Continental Association of African Neurosurgical Societies, the CANJ. I'm glad to tell you that with my team, we already organized 60 webinars since beginning of the pandemic, including many educational WFNS symposia. Today is webinar 61, and I'm glad and honored that this event is organized with the Education and Training Committee of the World Federation of Neurosurgical Societies. In this context, I would like to thank Professor Luis Borba, Chairman of the Education and Training Committee of the WFNS, for the opportunity to have such a wonderful collaboration. As we can see that today we are discussing an important topic, which is gliomas from anatomy to molecular biology. When I spoke with Luis Borba, we found that it is very important to focus on basic science, on molecular biology, on anatomy, on radiology, not only from the neurosurgical point of view. And as we can see that we have diversity of topics, we have many speakers from different continents. We have also among the speakers some young neurosurgeons, because we think that it's very important to share experience between eminent neurosurgeons and young neurosurgeons. Let me first of all welcome our speakers, who are going to be introduced by the moderators, and welcome the moderators. I will go by the order by which they speak. Professors Gabriel Vargas, Andres Serviu, August Dufo, Abida Shah, Jin Song Wu, Carolina Benjamin, Asil Ibrahim Subeh, Nader Sanai, Dorota Lobanska, you. And let me also welcome all our chairpersons and moderators, Professors Basant Mishra, Alistair Jenkins, and Azmi Elias. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. We have very interesting program today, which is divided into 3 sessions. Each session is 1 hour, and we have discussion at the end of each session. As we can see from this screenshot, as you can see at the bottom, we have already until yesterday 1,035 registrants over Zoom. Our series of webinars are also watched over the YouTube channel and the Facebook by thousands. You can follow this event through a live stream done over the Facebook page, and the address is seen over the screen, or over the YouTube channel of the SNS, or over the Neurosurgical TV of John Bennett. In this context, I would like to thank John Bennett. He's actually doing a great job in promoting our webinar series and in promoting neurosurgery. To all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. We are offering this type of certificates. Remind you that this event is recognized by the WFNS, and these certificates are approved by the WFNS. From webinar 1 to 50, attendees used to print certificates electronically. Then my organizing team changed the policy. Starting from webinar 51, certificates are sent automatically by email after the webinar is finished by a few days. However, I want to draw your attention that certificates are only sent to participants who are participating from the beginning of the webinar to the end of the webinar. Why? Because the organizing committee realized that some participants just participate for 5 minutes and they keep asking for certificates. Please, if you would like to have a certificate, participate from the end of the webinar, from the beginning of the webinar to the end of the webinar. Another important point is that names are going to be written over the certificates according to emails. And so please register from your own email in order to have correct names over the certificates. Our webinar series is organized either in collaboration with the Education and Training Committee of the WFNS, with scientific committees of the WFNS, with neurosurgical societies, whether national, regional, or continental, and sometimes with well-known universities. This table shows the last 10 webinars, and as we can see that not all registrants participate. For example, if we take webinar 59, which was WFNS Educational Symposium, we had 1,203 registrants. Only participants were 574 who participated to this event. And certificates were sent only to 322. And as we can see, the maximum participation occurs in the WFNS Educational Symposium. I'm glad to announce about the Pan-Arab Journal of Neurosurgery. I'm honored to be editor-in-chief of this journal, and the address is seen over the screen. Please submit your articles. Submission and publication are free. We are going to publish the June issue next week. Another important announcement, the CANS 4th CANS Congress will take place in Nairobi from 9 to 11 December 2022. Another important event is the 18th World Congress of Neurosurgery, which takes place in Cape Town, and that's a very important event, and it will be organized from 6 to 11 December 2023. Another important announcement is the Third Man's Congress, which is organized in Egypt from 13 to 16 December 2022. I'm glad and honored to be president of this Congress and to work with my friend Alberto Dell'Itala, president of the Mediterranean Association of Neurosurgical Societies. This event is organized with the British Society of Neurosurgery. I think Alistair Jenkins, my friend, who is the president of the British Society of Neurosurgery, is already joining us in this event, and it will be a good collaboration. of course, all of you are invited, and I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I give the mic to Professor Louis Borba to say his welcome note.
Okay, Professor Nasser El-Ghandour, all the participants, all the speakers, it's a great honor to us to have one more webinar, people from around the world to listen and to watch this wonderful presentation. When we start this series about education, let's talk about what is more simple to more complex. Now, our idea here in this symposium is start from the anatomy, molecular biology, surgical decision, in the future. What will be the future? In the future, we have here the young people, the young neurosurgeons that are doing a very nice work around the world. We have representatives here from the 5 continents. See, this information will be spread to the whole world. This is the education. This is the World Federation. It's education to the whole world. It's our goal, your decision to make these 2 years. Thank you all the participants, thank you all the speakers, and I give the word to Professor Bassant Misra, that is the first moderator of our session. Thank you, Bassant. Thank you all the participants. Thank all the professors here. Thank you. Go ahead, Bassant.
Sorry, I was muted. Good morning, good evening, good afternoon. Thank you, Nasser. Thank you, my dear friend Louis, for this opportunity. I see there are very distinguished professors in the program. Also, we are very promising young neurosurgeons talking about this. So this is what the policy of our new education committee chair, and my dear friend Nasser, who is probably doing the maximum number of webinars since last 2 years. Nobody has done more educational programs than him. So without wasting time, let me invite the first speaker for this symposium, Professor Gabriel Vargas from Colombia, who will be speaking on preventive neuro-oncology, role of early surgery in awake patient as a rule for low-grade gliomas. All the talks are for 15 minutes, and we'll have discussion at the end of the session. Professor Vargas, please. Is Professor Vargas? Yeah, right.
Turn on your microphone, please. Okay, good. Perfect.
Can you hear me? Okay, thank you.
Yes.
Thank you
Gracias,
very much.
Gabriel.
Thank you very much for the invitation. It's really an honor to be here, speaking to all neurosurgeons of the world. First word I want to say is I'm not as good expert as my next 2 speakers, Dr. Servio and Dr. Dufault, but I really want to say some words about this concept of preventive neuro-oncology and how we can apply that here in Colombia. But of course, those concepts should be applied for all neurosurgeons treating low-grade gliomas. So our goal is to really do a revision of what we do. Those are the hospitals where I work, Hospital Los Comuneros de Bucaramanga, Clínica Chicamocha, and this university here in Bucaramanga, that you are very welcome and invited to our events in October of neuro-oncology. I have nothing to declare in conflict of interest. And then the objective of this small talk is the rationale for early surgery in awake patient as a rule in low-grade glioma brain tumor surgery. This photograph is in 2019 with Dr. Dufault here in Bucaramanga, and I want to really emphasize that the concept of Dr. Dufault is the concept that I want to try to really develop during the talk. Of course, not with the expertise of Dr. Dufault, but try to say if we can apply some of these concepts. First thing is, what is this functional preventive neuro-oncology means? Preventive neuro-oncology, and of course, always we keep in mind that concept of maximal safe resection. What is prevention? Prevention means act of stopping something from happening. For example, act of stopping the tumor to kill or to deteriorate the patient. First thing that we need to do is how we can really stop the tumor to deteriorate the patient. We know that low-grade gliomas increase in size. So first thing for prevention means that we need to attack that disease as early as possible in order to prevent deterioration of the patient. But the second thing is of prevention is allowing or stopping someone from doing something wrong. That is the neurosurgeon. The neurosurgeon needs to have the knowledge of the anatomy, the knowledge of how to do awake surgery, how to look for the tracts. So those two things means this really good concept of functional preventive neuro-oncology, as I can see. And of course, these words from the book of Dr. Henry Marsh, that is, first of all, do not harm, and we need to keep in mind always, because most of the times we have patients without nothing, only seizures, that's it, and we need to keep those patients functional, but doesn't mean that we need to wait until the tumor attack the patient. We need to really do a surgery that prevent damage. So what means maximal resection in diffuse low-grade gliomas? Complete resection of all abnormalities in flare, which is good, but the boundaries of the surgery are the intrasurgical electrical mapping in order to preserve neural networks essential for brain functions with cortical and subcortical mapping. And we can really obtain that following neuropsychological assessment of the patients. And after the resection, we need to have, of course, also this concept of supratotal resection, which gets a possibility to obtain good follow-up and good survival, as Dr. Dufault shows in this article, showing us that a prolonged survival time following these concepts. So early surgery means increase of median survival and also improve the quality of life of the patients. Taking in consideration the molecular classifications, we have many different concepts right now to the WHO classification. Those tumors that I'm showing here on the screen are the tumors that WHO 2016 show us as low-grade gliomas. But now, in 2021, we have increase of the list mainly on the pediatric tumors that get a lot of different molecular patterns, but all of them, independent of the molecular biology, needs to have the same approach, trying to look for the biggest resection with preservation of the function of the patients. This I am showing here some literature about what is the relative survival, 1, 2, 3, 4, 5, 10 years survival rates of diffuse low-grade gliomas in different patterns of histology. And we can see here that through the time we can preserve, of course, in many cases, more than 10 years of survival if we do a good resection. Here we are showing here a literature review from the book of Dr. Dufault that dividing this for age, and we can see here, of course, that the younger the patient, the better the possibility of longer survival. So, for example, if we wait and see young people, 15, 14, that we have a lot of patients of low-grade gliomas waiting for the development of the disease, we cannot achieve this long survival. So we need to do as early as possible surgery. Some prognosis scores that we can review in the literature, we can see here that the better the Karnofsky scale and the younger the patient, we can obtain more survival. We cannot say that this is a disease that is stable. That word stable doesn't exist. Low-grade gliomas has a constant growth of approximately 4 millimeters in mean diameter per year, and transformation towards symptomatic at 48 months after radiological discovery. So, as Dr. Dufault mentioned, inactive low-grade glioma does not exist. Always is growing. And always is growing through the white matter, through the fibers, through the tracts. So this is a one special situation that we need to keep in mind. In comparison from simple biopsy to maximal resection, we can see here in this French glioma consortium from more than 1,000 diffuse low-grade gliomas, the difference in survival. This is the survival for biopsies, and this is the survival of maximal resection that appears on this literature. Different publications that are speaking to us that the velocity of diameter expansion in many of the low-grade gliomas that show us that in all of the literature we can say that the range of growing is different, but always those tumors are growing. So one of the goals should be maybe try to leave some tumor volume less than 15 centimeters, extent of resection more than 90%, and that was the reason that these French groups get an overall survival of 13 years, and Dr. Dufault told us that in the following, maybe they say that more than 15 years, of course many patients more than 20 years. This graphic, I'm sorry about the Spanish, but I want to show that what means low-grade glioma expectation. Just wait and see survival 5 to 7 years against early approach, maximal safe resection, awake surgery, neuromonitoring with a survival of 14 to 15 years. So the balance, of course, is going through the early surgery. And of course, as I said, in any of the patients, low-grade glioma and high-grade glioma, radical dissection impact the survival and the quality of life in both. Of course, we need to keep in mind what is the morbidity and mortality of the resection, and with knowledge we can achieve those goals. Evidence-based medicine is okay, but in these cases we need to do an individual-based medicine, trying to really achieve a good resection, a good goal. And these concepts of survival, functionality, but also neuroplasticity is something that we need to keep in consideration. Why? Because after the resection, maybe we can leave some tumor waiting some years in order to the accommodation of the function, and then we can again do a second surgery for a patient, keeping the patient function, and maybe not to do radiation as a first step of the surgery, wait for radiation, because we know that radiation maybe is not good for the white fibers, and it's good to maybe wait a little bit and try to do a second surgery before radiation. There is a proposal from Dr. Dufault that sometimes they give some chemotherapy with temozolomide, and then we can do a second surgery. So what is the best way to do surgery? Awake surgery, brain mapping, individual approach and preservation of quality of life. We need to know the white fibers, and those tracts are the main tracts that we need to keep in mind, cortical and subcortical, and we need to look for them, trying to make a functional limit of resection. Those tracts are the limit of the resection, not the anatomical boundaries, but the functional boundaries. As a neurosurgeon, we have a lot of tools, but the main tools here are the cortical monitoring, the awake craniotomy, subcortical monitoring, and we need to know the patient, do a multitask evaluation. We always keep in mind the occupation of the patient, try to do neurophysiological and neuropsychological assessment, and of course we need to keep in mind the quality of life of the patient. It's not the same thing that the surgeon has experience, confidence. It's not the same surgery, Dr. Dufault, that all of these partners that were with me when I was visiting Dr. Dufault. And of course the institution with most of the time, that not too much technology, and we use navigation many times in order to look for the focus of the increases of the contrast enhancement, but most of the time it's not necessary navigation for this time of tumors. Dr. Dufault emphasized that we do not to have only cortical areas in mind, but of course, as I said before, look for the tracts in real time. As we can see here, the difference between the sleep patient and awake patient, we can test a lot in awake patient, and we cannot do surgery at sleep in this kind of patient. And talking about right hemisphere and left hemisphere, both of them are very important, and I don't have time to explain those connections that are good, and we don't have that dominant hemisphere and non-dominant. In both hemispheres we have a lot of functions in both hemispheres. So we have a list of evaluations for left and front. I give some examples of multitasking. This is a patient engineer working on this on his work, and this is doing sewing during surgery. This is a neurologist working with his hand of his expertise during surgery. So this means multitasking, and we have, I don't have time for explaining this, but this is the kind of situation that we have at the end. We test before, look for the areas, cortical, subcortical areas, and we can obtain a big resection on this kind of tumors, of course. So a big cavity that, in conclusion, awake surgery from brain tumor surgery, when possible, offers the possibility of preservation of function and impact the quality of life of patient, should be the rule independent of the hemisphere. And that is all my 15 minutes, and then we can continue with the great talks of Dr. Servio and Dr. Dufault. Thank you very much.
Thank you, Professor Vargas, for a very nice introduction to the topic. I think there was a message from Professor El-Ghandour. Did you say that we should discuss now? I missed the chat.
Basant, I think discussion at the end of the session.
Yeah, so fine. So that
will be much better. Yes.
Yeah, good. So that's what we thought. There was a message from you, so I didn't see it properly. Now, so we go on to the next speaker by Professor Andres Servio from Argentina, who will be speaking on the awake surgery for low-grade gliomas, tips and tricks.
Thank you very much, everybody. I like to see, are you seeing my screen?
Yes.
Yes, only
please go ahead.
one chat or only one slide or both slides?
No, no, you need to go into the slide presentation mode. Your one side will be seeing. It is minimized.
Yes, I'll try to put in the right way. Now it's okay.
Yeah, that's right. Go ahead, please go ahead. Yeah, just fine.
No, thank you very much for having invited me, Professor Nasser El-Ghandour and Luis Borba. It's not easy and not fair to speak about awake surgery, give a lecture of awake surgery before Professor Dufault. So many of the comments and our slides are based on his research and studies. We had the opportunity to invite him to Argentina in 2006. So most of our presentation is based on his studies. So we decided with Professor Nasser to bring a lecture showing maybe from young neurosurgeons or neurosurgeons who want to start with awake surgery, showing them how to perform the surgery with different specific details, why, when, how, to whom, based on our own experience in awake surgery. I have nothing to disclose. First of all, where to or to whom perform surgery in an awake fashion. We have two main indications for patients with motor lesions near the motor area, like in the left side of the screen, or of course to perform motor and mapping of the language, like in the right side. When to perform the surgery in an awake fashion, it's necessary to have a collaborative patient, of course, with not so much strength or language affectations. There is some contraindication. Most of them are relative contraindication. It's not advisable to do an awake surgery for us in people with high body mass index or with emotional instability, psychiatric background, or maybe mini-mental status less than 24 points. Also, I don't like to perform awake surgery it's not a contraindication, but you have to be prepared to operate it on a patient with a high mass effect, for example, with a high-grade glioma. It's mandatory for a neurosurgeon who wants to perform awake surgery to be completely involved in the detailed knowledge of the different tasks you will have to evaluate the different process. You know that based on Professor Dufault and Berger studies about the new paradigm of the language, you have a phonological process, semantic process, and syntactic process. And you have different tasks to evaluate intraoperative, preoperative, and intraoperative, all the different pathways of the language. Because of the time, you do not have so many time to do awake surgery. So you have to decide exactly before the surgery. That's the reason why we look to a study in the preoperative planification, the patients, in order to know exactly with the functional MRI and DTI, which cortical and subcortical areas are involved near the language or the motor systems, in order to decide which type of intraoperative task we will use. It's completely different to evaluate the IFOF than the arcuate fasciculus. How to operate it on in an awake fashion? This is a diagram I drew regarding our operation room setup. I like to put the navigation with this is the tent in yellow. It's a transparent tent. At the beginning of our experience, we used to use a dark blue or black or green tent. Now we are using a transparent one. I will show you in a couple of minutes in order to see what happened in the other side of the surgical field. This is the clean area where the surgeon, the assistant, and the scrub nurse is, and the speech therapists are near the neuronavigation in front of the referent start of the neuronavigations in order to have plenty of space to interact with the patient. Anesthesia. There are different ways of performing awake surgery. You can do awake, or you can perform the surgery in a sleep, awake, asleep fashion using dexmedetomidine and laryngeal mask. We never use dexmedetomidine, we never use laryngeal mask. We perform a mix between, it's like a conscious sedation. We invited the patient 1 or 2 weeks before the surgery to the OR in order to make a complete explanation of the process to the patient, to build trust. You know, there is plenty of too many myths about the OR, like the OR is a place with the sacral music, no sounds, and this is not the real story. The OR is a specific place with a specific sound and a specific scent. It's necessary to familiarize the patient with all those things. So we invited the patient to the OR before the surgery, not only to make the preoperative evaluation of the upper air tract, but also to complete all those things. And we divided the anesthesiological process in 3 moments. The first moment is under sedation. We use propofol fentanyl, we put nasal trumpet, and we perform all the invasive procedures during this moment. Urinary catheter, blood pressure, intravenous fluid lines are put in the ipsilateral arm in order to leave completely free the contralateral arm to evaluate on the motor systems. Also, we perform the regional scalp blocks, put the Mayfield head holder, and and of course, perform the haircut and positioning in a very comfortable way the patient in the OR. Then we perform the approach, and when we start to open in the dura mater, we make the patient to wake him up, and then under hyperventilation to open the dura mater in order to have a complete relaxed brain in complete relaxations. Then we perform the mapping and surgery and the motor and language mapping and monitoring. And when we finish the surgery, we ask the patient to perform the Valsalva maneuver, and then again, under propofol fentanyl, we perform the closure of the approach. It's mandatory, please do complete regional scalp blocks, because one of the main complaints of the patient during the awake surgery, because of they can't move the head because of the head holder, is one of the main complaints is the pain. Not only in the skin incision, but also in the penis of the head holder. So we add some anesthesia in the penis and also under in the muscle under the Gelpi retractor, because it's one of the main complaint of the patient during the surgery. Regarding the positioning, for awake surgery, we like to perform in 2 ways. When we have patients with lesions in the anterior frontal and temporal lobes, I like to use this supine position with a pillow under the ipsilateral shoulder, or when the lesion is more in the most posterior portion of the lobe, frontal, temporal, or parietal lobes, I like to perform in the park bench positions. We never infiltrate the dura mater. I perform the anesthesia of the dura mater with topication, with cottons, with lidocaine. And please be completely sure there is no any gap in the dura mater in order to avoid the contact of the lidocaine with the brain. After opening the dura mater, all the cotton must be discarded in order not to be confused during the surgery. I will not speak about direct electrical cortical stimulations, but this is our sequences of surgery. After opening the dura mater, we put the subdural grip for monitoring of motor evoked potential. We perform the cortical mapping, starting with counting and picture nomination and repetition. Then, after identifying the safe entry zone, we perform the surgery most of the time with under free language or specific task. It depends on which tract, subcortical tract, would you like to monitor, and then subcortical motor and language mapping after, and then closure the approach. I will show you, we are using, it depends on the rule of 1 milliampere, 1 millimeter of the distance. I perform this type of remotion in the subcortical stimulation using dynamic subcortical suction tube. You will see now, this is here in the inferior portion is the motor area. This specific device, suction tube, is under 5, for example, milliampere. You see here positive stimulation. Then we put in 3 milliampere with continuous remotion of the patient. And when we reach the positive stimulation and the 3 milliamperes, I prefer to stop the surgery. Of course, you have no navigation to check, and also the double check, the patient is awake, so you can check the movement, the free movement of the patient. This is the tent we are using now, transparent. We put the reference starts of the neuronavigation in the other side of the surgical field. We are behind the patient. And at the beginning, we like to use the Boston naming type printed, but now I am using this iPad. You hear a sound. this sound put the stimulations, and then the patient must have to say, this is a tree, this is a rule, this is the telephone, like everybody here knows. And we decided to make our own device in order to evaluate that, like Professor Velo used to like to say, like a screwdriver. The patient needs to do this movement with the hands. Also, they have to put this screw in the middle of this line when we are evaluating the visuospatial abilities. And also with those toys, circle, triangle, the patient must put exactly in the same region in order to evaluate the visuospatial abilities. Which are the patient experience? When we offer the patient in the outpatient clinic that you are offering an awake surgery, the first impression of the patient is surprise. Then they start to thinking about the possibility, and almost 100% of patients after the surgery are really happy with the experience. Please, it's necessary to perform the surgery in a pleasant atmosphere. We put the temperature of the OR in more than 36 Celsius degree. I like to ask the patient to bring to the surgery their own Spotify list in their own cell phone in order to have their preferred music in OR. And there are some papers saying that maybe if you put some lavender like a scent, it's a good option to calm the patients. Continuous communication is mandatory, not only to contain the patient, but always to give anticipation of the maneuver you will be doing. For example, I will do this, I will do that, in order to the patient to know what are you doing. This is the main complaint of the patient. I repeat, head holder pain, position discomfort, and many of the time dry mouth. Our anesthesiologist put some humidify the lips during all the procedures. Specific details, I repeat, you need to do a fast surgery. It's not like a sleep surgery, because only you have progressive attentional deficit. When you operate it only in the subcortical region in the frontal lobe, you are always affecting the language, motor system, but also the attentional network. So it's necessary to have into consideration the time. Please remember to ask the patient to bring their lens, if they are using lens, to the OR in order to be in order to collaborate and interact with the speech therapist. I like to use with my scrub nurse sign language. I don't like to the patient to hear, give me a scissor, give me a scalpel. And also with my assistant, we use encrypted medical language. It's not advisable for the patient to become aware of some situations, like to say, this portion of the brain is infiltrating, the tumor is bleeding. I don't like the patient to hear these phrases. Some warnings, because we have this experience. Everything I have a awake surgery, I put this advertisement in the front door of the OR. I remember having once one of my colleagues entered the OR saying, oh, you are operated on a specific surgery or histological report. Someone pick up the phone and say, the pathologist says it's not a low grade, it's a high grade glioma. So I prefer to have this information whispering in my ear. And please confirm if you are using the same protocol like us in the anesthesiological, the sedation in the last moment of the surgery, because I remember once we finished, everybody was relaxed, everybody started to speak about different things of the surgery, and the patient was still awake. We like to perform a neurological and neuropsychological evaluation preoperative and the same evaluation postoperative 3 months in order to know how you modify the patient. This is an example. Professor Dufour will speak a lot about the difference between transilvian and transopercular approach. This patient was operated on transilvian approach, but the sequence is always the same. Pathological frozen sample after mapping of the cortical mapping, then the resection, cytoreduction of the tumor. After cytoreduction and remotion, subcortical stimulations, it depends on which tracks would you like to use. Neuronavigation maybe is not so accurate because of the brain shift, so I perform sometimes intraoperative, transoperative MRI in order to know when to extend the remotion in order to improve the extent of resection. In this case was one of these cases, and then to close the surgery with the satisfactory remotion with a very good motor function. Some contingencies you can have. Seizures, it's not advisable for the patient to have this, to become aware of this, not complication, contingencies. You see this patient, it was a colleague with a tumor near the cortical representation of the face. And when I was stimulating the subcortical area, you see, this is a seizure. We always use cold saline solution in the scrub nerves table. I prefer cold saline solution instead of rinsed lactato, but it's the same. Our anesthesiologists always have propofol ready to use. And remember to put levetiracetam in patients with seizures background or when you are planning to use a lot the cortical stimulation. Also, we use intraoperative electrocorticography. Another bad situation is ischemia. You see this patient was operated on in an awake fashion. And then in the medial portion of the tumor, we were doing some hemostasis and suddenly drop of the motor evoked potential and the patient developed complete motor deficit. I think it's not for the patient advisable to become aware of this situation. I put under sedation. I finished the surgery. I aborted the surgery with some small remnant here. The patient recovered very well the legs, but not so much the arm. This is the outcome in 70 cases. This is the first 58 cases. And you can see here immediately after the surgery, many of the patients worsens in the speaking about language, but after 3 months of rehabilitation, phoniatric rehabilitation, most of them recover very well. In summary, for us, awake surgery is a very safe procedure. It's mandatory to have a complete and detailed anatomical and functional knowledge in order to make a correct preoperative election of the patient and correct intraoperative selection of the task you will use. I am a great support of the teamwork with the anesthesiologists, radiologists, physiologists, and speech therapists, and also our scrub nurse. Thank you very much for your time.
Thank you, Professor Servio, for the practical tips and tricks of awake surgery in low-grade glioma. Very well appreciated. And we'll move on to the next talk in this session, the last one by the master himself, Professor Dufau, who doesn't need any introduction to a neurosurgical audience. He will be speaking on surgery for insular diffuse low-grade gliomas, transaporcular approach in the awake patient. Professor Dufau, please.
Thank you very much for your invitation, and thanks also to my two colleagues, Professor Vargas and Professor Servio, who demonstrated finally that this philosophy is really reproducible, and this is the most important for me regarding the young generation. You can achieve this kind of results with more or less without any technology, because in my operating theater, I do not use intraoperative MRI or your navigation or DTI or fMRI or even microscope. And nonetheless, I have 99% of good results. And today I would like to insist a little bit more about the insular low-grade glioma, knowing that just a very quick introduction about almost 1,000 low-grade glioma now and operated on consecutively. The survival, in my experience, is over 17 years, with 99% of patients enjoying normal life, including working full-time. And I would like to insist on the fact that when I started more than 20 years ago, the median survival was around 6 to 7 years. And on the recent papers we published, the median survival is now between 16 to 17 years, but also with a preservation of the quality of life in the vast majority of patients, at least for the 12, 13 years after the diagnosis, which is absolutely critical. I don't know why, but 1/3 approximately of this tumor, low-grade glioma, like to involve this so-called insular or paralimbic fronto-temporoinsular region. And of course, this is a challenge, as you know, because this is a deep location. So you know absolutely, you need to know absolutely your anatomy in order to operate this tumor, but not only how to reach the tumor, but also the deep connectivity, because the insula is very, very well connected. So it's absolutely critical in this location, as in all locations in the brain, but especially in the paralimbic system, for the young people to understand that you cannot operate with a high level of reliability the insula if you not have understood, did not understood and understand, the connectivity, and especially the functional connectivity. Why? Because when you will operate low-grade glioma, patient is one and he had just seizures, you have to understand that in the contralateral hemisphere, there was already an increase of the volume of the homotopic area, the contralateral insula, but also an increase of the functional connectivity. And this is the reason why you can remove the vast majority of the tumor in right or left hemisphere, and patients can recover because they will benefit from this compensation thanks to the contralateral side. And to obtain these results, of course, you have to be objective by doing systematically a neuropsychological assessment before and after surgery, exactly what we published in Young Oncology recently, with over half of patients with low-grade glioma who had a preoperative cognitive deficits. While for the vast majority of neurosurgeons I know, all patients almost are well before surgery. No, this is not the truth. And this is related to the invasion by the glioma before any treatment of the connectivity, which is the limitation of neuroplasticity, especially in this location, the inferior fronto-occipital fasciculus. So you need to do dissection by yourself and to correlate in your mental imagery with the intraoperative mapping you will do. And of course, you can use, if you want, pre and post-operative DTI, but this is not the most important. The most important is for you to do this kind of dissection by yourself, not only regarding the stem, but also regarding the cortical termination of the dorsal pathway, ventral semantic pathway. And then you can use, if you want, DTI, but I have the regret to tell you, and you know it, that this is not a function per se. So never DTI will give you this kind of very accurate information you can obtain in a patient awake into the operating theater by asking him or to do a real-time cognitive monitoring. In addition to the electrical mapping, which is not the most important for me, this is just the validation of your mental pre-planning. So you can use this knowledge and this confirmation, thanks to your psychological assessment in real time into the operating theater, in order to do a transopercular approach. Why? First of all, because you see better. And it's true in Montpellier, but it's true in San Francisco too. If you remove more the operculum, you have a better exposure of the insula, and this is critical to limit or even avoid vascular problems, especially if you do a sub-IL dissection. Then I had no spasm in 20 years of experience in this field, no papaverine in my operating theater. And I cannot lie because I have 5 to 10 visitors every week in my operating theater. Because it's not logical to split the Sylvian fissure, knowing that in 80 to 85% cases, low-grade glioma are not just located within the insula, but also involving the operculum. So why to split the Sylvian fissure? To take more risk of spasm, to remove the insula, and finally to remove the operculum, because the goal is to remove the tumor as much as we can. And the most important is because the morbidity is reduced. It's not just my opinion. I did an extensive review of the literature regarding the resection of glioma involving the insula, especially low-grade glioma, and you can see that 5 to 15% of severe permanent deficit by using a Transsylvian approach, while in all series, and not only my experience through the operculum, less than 5%. And remember, the goal is, first of all, to be careful about the quality of life of patients. And because for younger people like you, you cannot split the Sylvian fissure into the operating into the lab of anatomy. You can, but it's not the real truth. While you can really mimic what will happen into the operating theater in a specimen. So you will tell me now, yes, but if you go through the inferior frontal gyrus, especially in the so-called left dominant hemisphere, then you will induce aphasia because this is the so-called Broca's area. You have to re-insist on the fact that Broca's area is not the area of speech. If you do not believe me, neurologists now believe me, because they published this paper many years ago in Brain, and recently we republished a validation paper about not only the French experience, but also the Shanghai experience. Many thanks to Professor Wu, who will participate to this session, and to San Francisco also, many thanks to Mitch Berger. So that means that definitely we have to understand the connectivity underpinning these networks, and especially the dorsal pathway. And you will tell me, we know the anatomy. I will tell you, you do not know the anatomy. You do not know that the left arcuate fasciculus is running many more within T2 and T3 rather than in T1. We published this paper in Brain just 2 months ago by telling we do not know the anatomy of the pathways, speaking about the arcuate fasciculus. How do you want to operate the brain? Typically, speaking about the insula, the most important landmark in the depth will be to stimulate the inferior fronto-occipital fasciculus, and then the patient will have semantic disorders, language, non-language. Indeed, in the right non-dominant hemisphere, you can have also a very important participation in non-verbal semantics, because the right eye-4 is involved in multimodal processing regarding the semantics. You have to know it, especially to do a transcortical approach, because you can tell me the reverse. Oh, I can remove the right inferior frontal gyrus in the non-dominant hemisphere under general anesthesia. And I will answer you, be careful, because maybe you will induce modification regarding semantics, higher cognitive functions, but also mentalizing, empathy, emotion, theory of mind, social cognition. So please awake the patient, including in the so-called right non-dominant hemisphere, ask him, her to do recognition of emotion in front of him, her, and suddenly you will see that the right eye-4 will give you the deep limit of the resection in the paralimbic system, because you should know your anatomy that the eye-4 is running in the temporal stem, which is lateral to the anterior perforating substance. So no reason to have any problem with perforating arteries anymore. The function is protecting you of the anatomy, of the vascular anatomy. Especially, you can combine, of course, multitasking, semantics, and mentalizing tasks into the operating theater, or even to increase the level of self-evaluation of the patient. You will tell me so many tasks. Yes, but in 5 seconds. That means that this kind of surgery, I can achieve it in 3 to 4 hours without any technology around me. And especially at the end, you identify the somatosensory and the motor pathway into the contact of the posterior limb of the internal capsule, but also pathway involved in the control of movement. You see that when I stimulate, the patient stopped to move bilaterally. And finally, the deep gray nuclei also, when you stimulate, the patient will have articulatory disorders at the level of the triader. So what about the results? Most important, about my first 300 insular low-grade glioma, nothing very special. Patients are young, they have seizures in the vast majority of cases, and almost normal neurological examination. But remember, at least 50% of them had already some degrees of cognitive deficit regarding the higher cognitive functions. Definitely, I don't know why, but I have very few pure insular low-grade glioma. It's not my fault. I mean, my patients are coming from 5 continents, so this is the reason why I cannot understand why not to go through the operculum. When I was younger, I was probably like you. I did some mistakes by doing surgery in the right insula under general anesthesia. And I had 2 problems. 2, that means perforating arteries, so deficit with hemiplegia. Then I said, I will awake everyone. Since this period, new period, the 251 patients I operated on under local anesthesia, the rate of severe permanent deficit is 0. So do you want to have hemiplegia, sometimes 5 to 10%, or no problems? For me, of course, it's clear. I do not want to have any problem. And finally, that means that by taking care of 300 patients, 98% of them return to a normal life, with also 92% of them able to work full-time, plus an improvement of cognitions in 10% of them, plus a positive impact on epilepsy on 80% of them, whatever the location of the tumor, pure insular, but also sometimes involving the temporal lobe, and then by doing a mesiotemporal lobectomy. So in other words, the extent of resection, speaking about oncological issues, is not related to the volume of the tumor, because you will perform the surgery according to functional boundaries based on the connectome of this patient at that time. So the limitation is definitely for me the anterior perforating substance, because if you deal with it, that means that in essence, you already cut the inferior frontooccipital fasciculus. So maybe your patient will not be hemiplegic, but please do a cognitive assessment after surgery if you dare to do it. You will see that they are not normal anymore. And the second limitation to me is the access to the posterior and upper part of the insula in the left so-called dominant hemisphere, but sometimes it's complex in the right. And this is the reason why I can do a transcortical approach through the supramarginal gyrus paper I published recently. And finally, I can tell you that reoperations are possible also in the insula without increasing the risk of inducing any further deficits. The median survival, 72% of my patients are still alive in this specific location, speaking about so 300 cases, and the first one I operated on was 23 years ago. And to conclude, the paper I published recently in neurosurgery, only regarding the right insular low-grade glioma, Hugues-Dufaux against Hugues-Dufaux. When I was younger, when I operated on under general anesthesia, you can see by yourself, the return to work was 82%. And now under local anesthesia, the right, almost 96% of return to work, and the extent of resection is the same, plus the fact that I have no hemiplegia anymore. And if you do an extensive review of the literature regarding awake surgery versus under general anesthesia, specifically speaking about insular tumor, definitely the difference is very significant, very significant. Do you want to have 10 to 15% of postoperative permanent deficit, or 1 to 3%? In my experience, it's less than 1%. So my message is, in agreement with my introduction, if I can do it, you can do it. But you need to know the functional anatomy of the brain. And to do it, you have to adapt to each patient, thanks not to technology, which never will provide you this kind of information, especially that Broca's era does not exist, but a team able to provide the information regarding how the brain is processing in this patient at that time, not only cortically, but also at the level of the subcortical white matter tract, and to push according to the reorganization which happened before surgery. Remember that the brain reorganized, reshaped, with modification of the morphology and modification of the functional connectivity. And I will just conclude to show you that even in the so-called left insula, you can have participation by doing multitasking of network involved in control of movement and language and speech. You can see that when I stimulated the dorsal pathway, then the patient stopped. So that means that you can remove the so-called Broca's area. The patient can preserve the connectivity, so can return to a normal life. You can postpone, delay chemoradiotherapy by increasing the median survival, more than 17 years in my experience, but by accepting that never go to the anterior perforating substance, except if you can accept to have 10 to 15% of severe permanent deficit. I cannot. So now you have to adapt according to your own philosophy. Thank you very much.
Thank you, Professor Dufau. As are always very, very clear and direct message how to operate in this insular gliomas with the minimum of technology, which can be done anywhere in the world. And the limits, I understand the anterior perforated substance is your limit, but I think everybody has to have their own limit over a period of time. As we learn more and more, we can do more and more. So thank you very much. I think there are some questions. Professor El-Ghandour, would you like to take the questions or how do you do it?
No, please go ahead, Basant. You have many questions in the chat. You have 3 who are raising their hands. I don't know if they have questions or no, but they will be allowed to speak now.
I cannot see the hands, so please, can you invite them? Whosoever, I don't see anybody here.
Let me start by our colleagues who are raising their hands.
I think Professor Dufau, can you stop sharing, please?
Of course.
Yeah, thank you. Nasser, please.
Okay, now Ahmed allowed to talk. Ahmed, are you here? Ahmed, we have Abdullah allowed to talk. Abdullah, are you here? Please speak. And the last one, Julio. Everyone allowed to speak. If you like to have any discussion or to ask questions, please go ahead. Any one of you, 3 colleagues who are raising their hands, Abdullah, Ahmed, and Julio.
Sorry, I raised my hand by mistake. Thank you very much.
Thank you very much. Okay. So I think Basant, they are raising their hands by mistake.
Okay, so can I just take the question?
Yes.
There is first question from Dr. Agarwal.
Yes, please.
Do we have a problem with surface registration if scalp block is given before and it causes undulation of the skin on the forehead? I think any one of you can answer, the faculty. Do you have a problem with surface registration? I think he's talking of navigation, surface registration after the scalp block. Does it make a difference?
My answer is very clear. If you do not use your navigation, you have no problem of registration. Never with your mental imagery.
Yes, I agree with Professor Dufau, but if you want to use it, I agree, we have the same experience. We perform all the regional scalp blocks, less supraorbital and temporal. I perform further neuronavigation and then we block after because it's true, if you put some block in the supraorbital region or here, the neuronavigation less the accuracy. I agree with the question.
Okay, there is another question by Jamsid Islomov. What do you do if there is intraoperative brain edema?
In my experience, about 1,000 awake surgeries, you can believe me or not, but it never happened, including speaking about high-grade glioma, because I have a good team, and the answer is you need to have good anesthesiologists, and then no problem. I do not speak about the patients, of course, comatose before surgery, but the patient conscious.
I agree with Dr. Dufau. Edema is something that we never find. I wrote that is very rare, but it's strange. If something happened, maybe you need to check the position of the patient and maybe elevate the head a little bit. But many times with these kind of tumors, we don't have, we can really perform a good surgery without any problem with edema. So as Dr. Dufau emphasized, it's good the position of the patient and good sedation, not too much, and it's not a problem really with this kind of tumors.
Before I take the next question, I have a comment to make. We do most of our awake surgery, which I've been doing for last 22 years, in the lateral position, if possible, because this we find is more comfortable. And if the patient has vomiting or has fits, or he or she wants to pass urine, it's much easier because we do not catheterize the patient. I want to know from Professor Dufau, do you catheterize your patients, awake patients, or you don't?
In all cases, I do like you in lateral position, right, left. because it's good for the patient, it's good for the anesthesiologist, it's good for the intraoperative neuropsychological assessment, and it's good for me because, in fact, for younger people, do not be so afraid. I have a very poor mental imagery. I have just two positions of the brain in my brain, right, left, and you can operate everything thanks to that.
You do a urinary catheter, do you put it always or you don't?
No, I do not.
We also do not put, because that's a discomfort for the patient. And if you're finishing in 3-4 hours time and you are not giving any diuretics, which we don't, it's most of the time it's not necessary. For a man, he can pass in a urinal, you can give him if he wants to pass. For a lady, we put a lot of cotton around the patient's private parts so she can pee to that. So we don't use catheters. So that's something which I would like to share with you. And very, very interesting. There is one more question from Dr. Agarwal. When do you schedule the neuropsych assessment after surgery? How many days later?
Please, to my colleague.
Yeah, anyone, any of the faculty. When do you do the schedule, the neuropsych assessment?
For me, systematically perform 2 days after surgery and 3 months after surgery. I know that Professor Servio spoke about 3 months later, but it's very important. For instance, the patient I operated on in the left insula 2 days ago, she benefited from the cognitive assessment during this talk. And now I will go to meet her in order to adapt the post-operative cognitive rehabilitation she will perform during the next weeks in order to give her all chances to return to a normal life, including working full time.
I agree with Dr. Dufour. It's good to have really early neuropsychological assessment after the surgery in order to do some rehabilitation if it's necessary, so the patient can improve really quickly if something happened during surgery. So early neuropsychological assessment is the best way to follow the patient.
So there is another question from Dr. Wan Su-yung to Dr. DePaul. How to remove the tumor around the LSA?
Into the contact of the temporal stem, because the hypoph, the stem is running laterally to the anterior perforating substance. So I will stop at this level. If you want to remove within the anterior perforating substance, once again, you will have 10 to 15% of severe permanent deficit. And once again, is it possible to accept that for your patients? For me, it is not. And in all cases, even if you do a supratautorization, and you know that I love this concept, I introduced it for low-grade glioma, you will not cure patients because in all cases, you will see a recurrence after 5, 10, 15, 20 years. So why to induce any severe permanent deficit when you know that even with a long-term follow-up, it's impossible to cure them? I would prefer to come back.
Okay, there's another question from Dr. Bishnu, Partha Bishnu. Professor, are you using fluorescence guidance for ensuring a more complete resection of glioma?
More complete resection would mean according to functional boundaries. How do you want to remove a tumor visible if you can push on the reverse and to achieve a supratautorization? Stop to see the glioma into the operating theater if you want to see your patients living longer and better. Think about their brain and think that in diffuse glioma, the brain is invaded in the duct.
There is one more question, I think, by anonymous attendee. He has not given his name or her name. Physical disorders can be treated, will recover some or all function over time, but how can we do with cognitive disorder? So I think the question is whether the physical disorder can be treated, what do you do with the cognitive disorder after surgery? I understand, probably that's the question. Any one of you, please, go ahead.
Post-operative cognitive rehabilitation according to the job, the hobby, the willingness, the lifestyle of each human being, à la carte.
the cognitive situations, many of the cognitive deficits can improve with plasticity and things like that. So with good rehabilitation, it's possible to get better neurocognitive rehabilitation, of course, in many times, at least improve from the plateau of the patient after the surgery, for sure. It would really strengthen neuropsychological rehabilitation. And talking about that question about the fluorescence, there are many papers talking about finding spots of fluorescence during surgery, and those spots are meaning of transformation of low grade in high grade spots. So the use of that kind of surgery for low-grade gliomas, according to those papers, is that. But as Dr. Dufault emphasized, the limits of the resection, if we really want to resect the tumor, is not useful use fluorescence for that situation.
Professor Basant, I
yeah.
make a comment. I
Please,
agree
go ahead.
completely. Yes, I put in my, I agree with Professor Dufault, of course. I put in my lecture, we believe in the 3 months evaluation of neurocognitive disorder, because after surgery, most of our patients has some affectation of the language and the neurocognitive areas. Of course, after the surgery, we evaluate it and we put some neuropsychologists, we incorporated psychiatrists and psychologists in our department in order to evaluate, like Professor Dufault says, immediately after the surgery. But I know those patients will have some dysphagia and some neurocognitive affectation, but you know, it may be transitive because you need rehabilitations. I put 3 months is because the time, almost all the patients after 3 months recover very well. Of course, you have plasticity up to 12 months, but the great difference is between the surgery and the 3 months. But I agree completely with Professor Dufault regarding the necessity to evaluate immediately after surgery in order to organize the rehab.
Okay, there is a question from a nurse. His nice presentation. I'm a nurse working in a neurosurgical unit. What is special attention regarding nursing patient post-surgery?
Stand up the day after surgery. No nursing. Everything should be simple. You have to avoid thrombophlebitis, any complication. You have to continue to tend toward a normal life, plus 10 hours after surgery. This is my philosophy.
So there is one, I think you have already answered. Dr. Pirsad has questioned what to do preventing brain edema during operation. You said that you don't. Then there is a question from Dr. Wan Su Woon to Dr. Dufault. Which route do you use to remove the tumor at zone 3?
Zone 3, to be honest, I don't know where it is. I'm sorry about it, but I do not use classification. So you mean the posterior and superior one? As I said, so if it this area, it's through the supramarginal gyrus, so transopercular again, according to the fact that at this level it's much more complex because you have not only the arcuate, but also the SLF3, the lateral part of the superior longitudinal fasciculus, which is a little bit more lateral to the insula. So this is the reason why you have to be very careful about the connectivity in order to have this beautiful access to the posterior and upper part of the dominant left dominant insula, because in the right, in the vast majority of cases, it's easier to do it.
Thank you very much. I think we have now gone much beyond time. Thank you, Professor El-Ghandour. Thank you, my dear friend Nasser. I think we'll close this session and you please take over. Thank you very much, all the speakers, and thank you, Nasser, for this opportunity.
Thank you very much, Basant. We move to our next session. Jenkin Alistar will be the moderator. Jenkin, are you ready?
Yes, thank you. Can you hear me?
Yes, of course.
Welcome everybody to the second session, and thank you to my friend Nasser for the kind invitation to join you today. I have to say, we haven't enjoyed very much about the pandemic, but the sudden realization we had to continue to educate people and to learn ourselves has encouraged us to explore this new medium. And although I'm a people person, I like being with people, we can't do it all the time. And this is a fantastic resource. And 61 down, well done, Nasser, that's absolutely fantastic. This very varied session will be opened by Abhilash Shah, who I saw on the screen. Oh, there you are a minute ago. He's from the King Edward Memorial Hospital in Mumbai, which I assume is Vasant's direct rival. And he's going to talk to us today on the anatomical basis of glioma surgery. Thanks very much.
Thank you, Professor Jenkins. Thank you, Professor Nasser. Thank you, Professor Borba, for this kind invitation. And it is my honor to present in this webinar and to be amongst stalwarts. I'm going to present to you today the anatomical basis of glioma surgery, how by performing white fiber dissections, we have come up with our own strategy of performing surgery. We have seen the monitoring phases, we have seen whether to do with it awake, whether you use gadgetry, whether you don't use gadgetry to perform the surgery. But before doing all this, it is better to go to the basics of anatomy and understand the cortical and subcortical anatomy of this beautiful organ that we see in front of us. So if you have to do glioma surgery, not only do you have to understand the cortex, but also the subcortical anatomy. So very recently, we published this article on the architecture and function of the white fibers of the brain. So basically, by doing this dissection, I've developed a three-dimensional understanding of how these fibers run. And I've divided into 5 groups to make it a bit simple to understand for someone who is starting white matter dissection. So there are 4 horizontal layers and 1 vertical layer. The horizontal layer is the superficial group, or this yellow circle, that is the short association fibers or the short arcuate fibers. The second group is the middle group, which consists of the long association fibers, that is the SLF, the arcuate, the ILF, the MLF, all those fibers. The deep group are the association fibers that lie in relation to the ventricles. That is, you have the fornix, the stria terminalis, stria medullaris thalami, etc. And the central group, which runs right in the center of both the hemispheres, are the commissural fibers. So the corpus callosum, the anterior posterior commissures, the habenular commissure, and the hippocampal commissure. While understanding this anatomy, I realized that the commissural fibers do not cross this vertical group of fibers. They are connecting the 2 hemispheres, but they remain medial to this. The only white fiber that crosses is the anterior commissure as it crosses beneath the internal capsule. The vertical layer consists of the projection fibers, or as we know, the internal capsule and the thalamic radiations. So another fact that I learned while performing this dissection is fibers that are medial to this vertical group do not cross laterally, and fibers that are lateral to this group do not cross medially. Coming back to gliomas, a lot has been said about gliomas, prognosis, supramarginal resection, safe maximal resection, but a lot has been unsaid about the origin of gliomas. Basically, a glioma arises from all these glial cells, which also have a lot of function, as you can see in this cartoon. Professor Yassergill, in his theory, said that glioma propagated from the subventricular zone and grew towards the cortex or the subcortical region. And basically, when they propagated all towards the ventricle. And sometimes the shape would be a wedge shaped because they followed embryological and vascular pathways. So this is the way he believed that these gliomas spread. More recently, Professor Berger wrote on neural stem cells and origin of gliomas. According to this, neural stem cells, which are multipotent, have been isolated from the subventricular zone, the lining of ventricles, the dentate gyrus within the hippocampus, and the subcortical white matter. So the subcortical white matter already has some neural stem cells which are pluripotent. And it is when these cells are transformed by whatever mutation or by some genetic mutation or a 2-hit theory, that is when the transformation into the glioma occurs. This is what my understanding of gliomas has come to. Professor Dufau, in his wonderful book on diffuse low-grade gliomas, has also written a chapter on origin of gliomas. And he has a functional theory, he has a molecular theory, he has an environmental theory. And it is a very interesting thing to read, and it increases your understanding on the subject. Now, based on my anatomical knowledge, I realized by looking at the gliomas, by looking at their images and looking at them surgically, that gliomas can be, apart from them being diffuse, gliomas can be surgically approached by understanding that they arise from a named white matter tract and that they displace the adjoining normal tracts. So this is the basis of the classification that we propose, that gliomas, this is a localized group of gliomas that will arise from the short arcuate fibers. The short arcuate fibers are those fibers that are connecting various gyri to each other superficially, and in the depth, they are connecting to the long association fibers and also to the other subcortical network. So this is what we call as the localized group of gliomas, which remain confined to a gyrus in the initial phases. This is the diffuse group of gliomas, which arise from the long association fibers. So as you can see, this is the cingulum. A glioma gets transformed here, arising from the region of the cingulum and traverses the pathway of the cingulum. This is the connection of the cingulum to the parietal lobule, and this is how the glioma traverses, as I will show you in some radiological images. And when you come to the corpus callosum, if you understand how the corpus callosum radiates, how the radiations of the corpus callosum are, you will understand the spread of the gliomas. They also tend to be diffuse and they tend to be bilateral. So based on this understanding, we published this paper on the anatomical extensions of gliomas on our radiological evaluation. So if you see these tumors, this one that is arising in the region of the superior frontal gyrus. So I would like to call it that it is arising from the region of the short arcuate fibers of the superior frontal gyrus. This one is arising from the inferior temporal gyrus, the short arcuate fibers of the inferior temporal gyrus. So it is not going to affect any long association fibers. It is only going to push them by pressure. It is not going to destroy them. Similarly, this is a tumor in the inferior parietal lobule. It is again displacing the fibers medially, inferiorly, or superiorly. It is not infiltrating the tumor. This applies to both low grade and high grade. As I was telling you, this is a cingulum, a tumor from the cingulum. So if you see this parietal connection of the cingulum and you try to trace this, understand this extension, you see that it is extending along the parietal connection of this cingulum. Again, it is arising on the middle part of this vertical fibers. It will never cross it. It will extend in the direction of the cingulum. Similarly, this is an insular glioma, which is spreading in the regions of the IFOF. I know Professor Dufab has published a paper based on this classification of insular gliomas based on long association fibers and some time back. So this is a tumor that is spreading along the IFOF. This is a tumor that is classically going along the uncinate fasciculus. So what we did is, and before we go to the next, this is a tumor of the corpus callosum. So if you look at this image, you're going to think this is a multicentric glioma. It is arising from here. There is one part of it is here. There is one part that is here. If you understand the fibers, this is completely a corpus callosal tumor. This is the callosal radiation. So this portion of the tumor is part of the ventral callosal radiations. It is going from the splenium. It is involving the forceps major that's going bilaterally. It is going beneath the ventral part and going to the ventricle through the tapetum. And this is how it is spreading onto the other side. And in multicentric also, there are anterior callosal radiations, anterior ventral callosal radiation, and that is how it reaches this. So this is completely a tumor of the corpus callosum, and it can be completely understood by understanding the anatomy of the white fibers. Now, based on this understanding, we went a step further to realize whether tumors that arise from the short arcuate fibers, can we are able to surgically excise them en masse by forming a beautiful plane around the tumor. And this surgical concept was proposed by Professor Goel. And this was our paper published on our early experience with 74 patients. So if you see this tumor, it is arising in the SMA, in the supplementary motor area, right in front of the precentral gyrus. It is displacing the vertical fibers posteriorly. It is displacing the SLF inferiorly. And we have performed an en masse resection for this tumor. This is our surgical strategy for tumors arising in the short arcuate fibers. We can perform monitoring. We can do it awake. We used to use neuronavigation. We don't use it anymore. Sometimes most of the times we use intraoperative ultrasound. We use monitoring, but the need of it has minimized in some cases because we are able to identify the tumor and go around it and form a beautiful plane, as you can see in this video. So this is the initial part. If you slowly by experience, you try to visibly, you will be able to differentiate between the normal and the abnormal, especially in the case of a low-grade glioma. So this is the kind of a plane that is being developed around the tumor, and the whole tumor is being removed. Again, in this kind of strategy, the use of bipolar coagulation is minimized, so the effects of an ischemic injury are completely minimized. You do not damage much of the structures, and if you understand that the normal tracks are displaced, then you will avoid injury to them also. I'll go fast for the want of time. So this is an en masse surgical strategy. From the feel of the tumor, you are able to develop this kind of plane and remove the tumor. And at the end of the surgery, you will see that these are the normal white fiber tracks that are there. You will ask me, how will I say these are normal? Actually, when you understand the 3D architecture of white fibers, you start understanding. Sometimes when I'm operating, I feel, oh yes, now maybe this is the SLF. I definitely cannot see it, but the three-dimensional concept comes, just as Professor Dufau says that you can do surgery without any kind of microscope, without any kind of monitoring. Yes, he can do it because his anatomical understanding is perfect, and we can also do it. And I have been doing it because I understand the anatomy. So this is the resection of the tumor in the supplementary motor area. This is the post-operative transcranial motor evoked potentials. As you can see, they are normal. So again, another tumor in the close proximity of the precentral gyrus. Again, we have performed a en masse resection. I'm not going to go into the video. And this is the post-operative status of the patient at the time of suture removal. And you can see she has no deficit. So these are some ultrasound images. So you can see this is the pre-op image of the low-grade glioma by ultrasound. And this is the post-operative cavity where the tumor has been excised. And this is, you can see the resection in these images. Again, some tumors that I'll quickly show, pre-operative and post-operative. So basically, you don't need to rely on tractography. In the earlier times, yes, you can perform a tractography so that you understand where it is. But again, mind you, the tractography should be performed by you yourself, not by a radiologist. And you will be able to perform the tractography when you know the anatomy, not otherwise. So this is again a tumor in the middle frontal gyrus. This is a tumor of the superior parietal lobule. So as I said, the fibers are displaced lateral to the tumor. So you come from medially and you perform this resection in en masse fashion, and this is the result. Again, another tumor in the superior parietal lobule, and this is the extent of resection that we have achieved, and this is the specimen that has been resected. This is an important area for tumor surgery. This is the temporoparietal occipital junction. There are a myriad of tracks that come here: the IFOF, the anterior commissure, the fibers of the optic radiation, the fibers of the tapetum, the fibers of the middle longitudinal fasciculus, and the fibers of the arcuate fasciculus. They all come together in this location. You cannot damage this area, be it on the right side, be it on the left side. You cannot damage any of these tracks. But if you know that the tumor is arising from the short arcuate fibers, you know that the long association fibers are displaced medially, and you are able to perform a resection. These are rare tumors in the occipital lobe. And again, we have performed an en masse resection. You can see the sonography post-op or pre-op and post-op. You can see the cavity. Coming to insular tumors, we had a beautiful discussion beautiful lecture by Professor Dufau. So the anatomy of the insula and the anatomy of the tracts is very important. So you open the operculum or the curtains, and you see this insular lobe, the short and the long gyri separated by the central sulcus of the insula, which runs in the same line as the central sulcus of the cerebral hemisphere. This is just a dissection that I performed to show the relation of the insula to the various parts of the ventricle. And these are the white fibers of the insula. So firstly, you will have the arcuate fasciculus as it is turning here, the horizontal vertical segment, and going all the way inferiorly in the temporal lobe. This is the uncinate fasciculus. This is the IFOF. This is the region where the uncinate and the IFOF are run very close to each other. This is the region of the insula where some part of the putamen has been removed now, and you can see fibers beneath it. Now I've lifted the arcuate fasciculus, and you can see the IFOF running. Just beneath the IFOF, you have fibers of the optic radiation. It is very difficult to separate these fibers in the sagittal stratum in this location, but more anteriorly, maybe you will be able to separate it. This fiber bundle that runs above the arcuate is the SLF2 and the SLF3, which cannot be anatomically separated very easily. Once you remove the whole of the gray matter of the insula, this is the internal capsule, the entire extent, the anterior limb, the genu, the posterior limb, the sublenticular form, and the retrolenticular part of the internal capsule. This is the optic radiations as they go to the occipital lobe. So these are the basically tractography images showing the major fibers in the region of the insula. So whether you do it by a transopercular route or a transsylvian route, that is your choice, and that is if that is your how you are trained to do it. Basically what I'm saying is insular, again we are dividing insular tumors into two types. So diffuse tumors are those that are either arise from a particular part of the operculum or the short arcuate fibers in the region of the gyri of the insula, and the diffuse tumors of the insula are those that traverse along the long association fibers of the insula. So this is a tumor on the left side in the pars opercularis. Again, we have used neuronavigation in this case. The patient refused awake surgery as he was very apprehensive, but in spite of this, we went in ahead and did this surgery. I'm not going to go into the detail, but I'm just showing you that the anatomical concepts helped us to perform an en masse resection, even in this case, preserving all this vasculature. And the patient did well following surgery. You can see this is the local language, but he's able to speak with some mild dysarthria, which recovered within the next 2 days. This is the first day after surgery. And this is the post-operative DTI showing the tumor resection and the intact fibers. So this is what I call localized group of insular tumors. As you can see, they're localized to the insular gyri. Again, this is the preoperative and postoperative images that you can see. This is another technique that I performed when I was a younger, maybe 7-8 years back, when I was having some difficulty identifying the normal vessels from the abnormal vessels in the region of the insula. I just used this ICG to identify a long perforating artery that was going on to supply the hemisphere. And I separated the tumor from this region and basically saved the vessel. So as a young neurosurgeon, if you need some kind of aid to help you, you can go ahead. But as you improve in your anatomy, obviously you will be able to do this without the aid of any kind of adjuncts. So these are just some preoperative and postoperative images. So this is what I was saying. This is a tumor that grows along the IFOF. So if you understand this, the resection becomes easier. In this, of course, you do not perform an en masse resection for diffuse tumors. You have to go for it piecemeal, and then you can perform a good resection. So this is the postoperative image. This is again a tumor that is going towards the IFOF, or going frontal and temporal in the lateral part of the temporal horn. And this is the postoperative resection that I've done. This is again a tumor that is growing along the uncinate. They are different from the localized group of insular tumors. So this is a tumor that is going along the SLF, the SLF1, or the middle part of the SLF. And this is the course of the SLF1 on the middle aspect of the hemisphere. Again, as I told you, that they are limited by this vertical group of projection fibers. And this is the resection that we have performed. Coming to the limbic and paralimbic system, they are very commonly having tumors in this region. And it's important to understand this anatomy. So this is the Papez circuit, the hippocampus, the fornix, the mammillary body, the mammillothalamic tract, anterior nucleus of thalamus. This is the anterior thalamic radiation. This is the cingulum as it comes back to end in the hippocampus. And this is the dissection that we have performed about almost 10 years back. And this was our publication on the subject. This is the entire Papez circuit that has been dissected outside. Coming to tumors of the limbic and paralimbic system. So you see this region of the cingulum, a tumor arising along the cingulum and approach through an interhemispheric pathway. These are just tractography images to show you where the tracks are. And again, these have been performed by me, not by a radiologist. So this is a tumor in the isthmus of the cingulum, again approached by an interhemispheric approach and operated, and you can see the resection. This is a tumor in the region of the parahippocampal gyrus, and you can see this approach that we have used, which I will show you anatomically in the next few slides, and performed a beautiful radical resection. So anatomy of this region, basically the optic radiations, the IFOF, they enter the temporal part of the brain, running above the temporal horn. So in front, in the anterior aspect of the temporal horn, there is an area here which is devoid of any major white fibers. So all these fibers, they are in the roof and in the lateral part of the horn posteriorly. So if you enter the temporal horn to go to medial temporal tumors, in this region, you will avoid any injury to the white fibers. This approach was devised by Professor Goel a long time back, and we are using it also for epilepsy surgery. And this is the kind of resection that we perform, a total en bloc temporal lobectomy with an amygdalohippocampectomy. And as you can see this image, this is the pin you can see, and this is the area of approach, and you will avoid injury to any of these optic radiation fibers. And this is a recent publication on the subject. So just some examples of medial temporal tumors operated using this approach. You can see the preoperative and postoperative images. Again, a high-grade tumor that was operated. This is in the parahippocampal gyrus, and you can see the resection using this approach to the middle temporal gyrus. Lastly, coming to corpus callosal tumors. So what I've done with this corpus callosal dissection is divided the fibers of radiations of the corpus callosum into dorsal radiations, these purple ones that go superiorly. Then you have posterior radiation, that is the forceps major that goes posteriorly, the forceps minor that goes anteriorly. Then this is one set of fibers that goes superior, anterior, and posterior. There is one set of fibers that goes inferiorly and laterally. That is the tapetum. So this is the posterior ventral callosal radiation. And you also have some callosal fibers that come ventrally from beneath the genu and go to the region of the basal ganglia. And that is how the corpus callosum connects to the temporal lobes. See how closely in relation they are to the IFOF. So which you understand this anatomy, this was recently published, you will understand the spread of a corpus callosal glioma. So if this looks bizarre, but it is not bizarre, it is going through the dorsal callosal radiation, it is going to the forceps major, and it is also going towards the tapetum. And this is some DTI constructed, but if you see in this image, you will see that they do not cross the projection fibers. So this is again the resection that we performed. This was of course a high-grade tumor. This is a tumor that I've recently performed from the region of the forceps minor, and you can see the resection of this tumor from a unilateral approach. This is a tumor of the splenium. Of course, I did not go to the other side too much in this, but this is the radical resection that I have performed, use understanding just based on the understanding of the white fibers. So basically, to conclude, anatomy is the key. Before doing your surgery, you have to understand the subcortical anatomy. And believe me, it helps you beautifully to go ahead with your glioma surgery. Thank you very much.
Well, thank you very much indeed, Dr. Shah. Absolutely beautiful. And anatomy, as you say, anatomy is key. I'm reminded constantly by one of my ex-trainees who sadly stayed on in the unit, who said to me that I said once to her, something like, I know quite a lot of neuroanatomy, but not much about the gray and the white bits. And I think we know that the gray and the white bits are the important thing. Another quote, to be honest, looking at those beautiful pictures, reminds me of a friend of mine who was lecturing a bunch of students. And he put up a picture of a dissection and said, if you don't find this beautiful, you ought to leave the room now because neurosurgery is not for you. So thank you very much. And we will move on, take the discussion at the end. All the way from Huashan Hospital in Shanghai, Jin Song Wu is going to continue with the anatomical and the specific thing of gliomas in the cingulate gyrus. Dr. Wu.
Thank you, Professor Jenkins. It's my great honor to be invited by Professor Nasser and Professor Bob for this event. And I think this is a training course for young generation neurosurgeons. And the topic today will be the anatomy and the surgical techniques for cingulate gyrus glioma, how we do it in our surgery. So in name of the cingulate gyrus, it is one part of the mesocortex. It forms borders between the isocortex and allocortex. In the transitional area of the cerebral cortex. Mesocortex is essentially the same as limbic, paralimbic cortex, as all of those transitional areas are found exclusively in limbic and paralimbic region and vice versa. Mesocortex is defined based on its cytoarchitectonics and histology, while the paralimbic cortex is the cortical area that lies close to the subcortical limbic structures. One hypothesis is that the cortex should be viewed as a concentric ring of the allocortex, mesocortex, as well as the isocortex. In 1937, James Pepys proposed that the circuit connecting the hypothalamus to the limbic lobe was the basis for emotional experience. Pepper's circuit goes through the hippocampal formation, including the subiculum to fornix, and then to mammillary bodies, to mammillary thalamic tract, to anterior thalamic nucleus, to cingulate gyrus, and then to cingulum, and then to the parahippocampal gyrus, and then to the endorenal cortex, and finally go back to the hippocampal formation. So here you can see the dotted line means the radiation, not specific fibers. It not be confirmed in the anatomy cadaver studies. In 1952, Paul MacLean reconceptualized the Pepper's circuit to the term limbic system. The limbic system, many studies has been done to analyze the anatomy and the function of the Pepper's circuit. Many scientists have proved that the circuit is related to memory and emotion. The limbic system, the modified term of Pepper's circuit proposed by Dr. MacLean, is thought to be involved in the same functions, and besides behavior, motivation, and affection. In 1905, Dr. Brodmann reported area 24 was ventral ACC, which means anterior cingulate cortex. It occupies most of the ACC in an arc around the genicle of the corpus callosum. Its outer border corresponds approximately to the cingulate circus. Cytoarchitecturally, it is bounded internally by the pregenial area, Brodmann area 33, and externally by the dorsal anterior cingulate area 32. Here is 32, 33. In 1907, Brodmann reported ventral PCC, which means posterior cingulate cortex, as area 23. Brodmann here. Brodmann regarded it as topographically and cytoarchitecturally homologous to the combined with the dorsal PCC, Brodmann area 31. Yeah. These were the first report about the distribution of cingulate gyrus. In recent years, neurofunctional studies have widely adopted 4 sub-region model. Vogt summarized the 4 sub-region model and gave the borderline of new distribution on the cingulate gyrus. The model is based on cytoarchitecture and functional studies. Based on the 4 sub-region model, it is necessary to discuss surgical techniques and functional outcomes. ACC here you can see in red. And MCC, PCC, and the retrosplenian cortex, RSC. So this is the 4 subgroup of the cingulate gyrus. And the ACC, you can see it beneath the pre-SMA, pre-supplementary motor area. And the MCC subgroup beneath the SMA region cortex. And the PCC just beneath the paracentral lobule, and the RSC was covered by the PCC. And here you can see a vertical dashed line indicate to the line between the pre-SMA and SMA region. And here you can see the precentral circus, central circus, and the posterior central circus. And the ACC, it was regarded be responsible for the emotion experience, including the pain integration. And MCC will be responsible for the fear avoidance and also the skeletal motor orientation. And the PCC will be responsible for the visual spatial orientation, as well as the self-relevance assessment. And RSC, it was regarded as be responsible for the memory access. Sorry. So the cingulum bundle is one of the most distinctive fiber tracts in the brain here, forming a near complete ring around the orbital frontal corticals along the dorsal surface of the corpus callosum. The cingulum is not a unitary fasciculus, but a united bundle comprised of several association fibers connecting ACC and the PCC, associating with the frontal and the parietal cortex and extending to the anterior thalamus region and the parahippocampal region. Anatomy structure of the limbic system are not easy to be presented in gross anatomy. So 3D reconstruction makes it possible. Here you can see this is the cingulum, and this is the lentiform nucleus, the caudate, the thalamus, the hippocampal formation, amygdala, and the subicula. The glioma will be originate from the white matter tract. So for most of the cases, the cingulum will be destroyed by the tumor lesion and the resulting neurological dysfunction deficits before surgery and also after surgery. So this illustrator show the blood vessel system of the cingulate gyrus. Here you can see the anterior cerebral artery A1, A2, and here you can see the orbital frontal artery supply the subgenial region of the cingulum, of the cingulate gyrus. And here is the anterior medial branch of the frontal lobe. And here is the intermedial medial branch, frontal branch. And here you can see the posterior medial frontal branch. And here you can see the paracentral branches too. All of these frontal branches originate from the callosal marginal arteries, A3. And the parietal occipital branches originate from the pericallosal arteries, M4, supply the superior parietal lobule. And here also you can see the PCA. In one of our retrospective observational study of our case series of cingulate gyrus glioma, totally 95 adult patients in the past 6 years was included in this observational study. And the tumor, most of the tumor before operative diagnosis was glioma grade 2 to grade 4. And the 4 sub-region model was used, corresponded to Dr. Volk, ACC, MCC, PCC, and also ISC. And the tumor lesion was divided to pure CG glioma. That means the tumor lesion located only inside the pure cingulate gyrus. And diffuse cingulate gyrus glioma. That means the tumor lesion invaded in the medial aspect of the frontal cortex as well as the parietal cortex. So these slides show the distribution of our case series. So you can see most cases are located in the ACC, PCC, MCC, and ACC, MCC combined, and also PCC, MCC combined. So this slide shows the surgical approach and also perioperative multimodal techniques that will be used for our cases. So typically for ACC patients, we prefer to use general anesthesia, intravenous general anesthesia. And during operation, no specific intraoperative neurophysiological monitoring was emphasized for ACC lesion. But for MCC lesions, we prefer to use awake mapping. We prefer to use awake craniotomy, and during surgical procedure, we prefer to use the cortical and the subcortical mapping to delineate the motor cortex as well as the language cortex, as well as the subcortical motor and the language fiber tracking.
In this video,
here we will show
three
three illustrative cases. One is ACC tumor, another is MCC tumor, and finally will be a PCC tumor.
No seizures, no
so for different cases, like we prefer to use different surgical
neurologic examination was normal and past medical history was not remarkable. MRI scans revealed a tumor of the left anterior cingulate gyrus. The lesion showed hypointensity on T1 and hyperintensity on T2 FLAIR images. Contrast enhancement was observed. A preliminary diagnosis of anterior cingulate glioma was made. DTI tractography was done next, and the cingulum bundle and pyramidal tracts adjacent to the tumor were delineated. The frontal ascending tract can also be seen here lying close to the tumor lesion. 3D brain reconstruction enabled clear observation of the eloquent subcortical fibers. This multiple information aids in surgical planning and will be integrated for neuronavigation. The patient was laid in a supine position with the head flexed. An MRI-compatible head frame was used for fixation and precision navigation registered. Following an arc incision, a rectangular bone window was made close to the sagittal sinus. The surgical plan was to resect the tumor under general anesthesia using the translongitudinal fissure approach. After dural opening, the medial side of the cerebral hemisphere was covered with gelatin sponge, and the superior frontal gyrus was retracted gently to expose deeper structures without causing injury. The callosomarginal artery and cingulate sulcus were located using neuronavigation. Next, the pia mater was cut and the blood vessels coagulated. The cortex was then incised and the tumor gradually resected using CUSA. Finally, the area was irrigated and cleared.
Here you can see the genu of the corpus callosum.
And fluid gelatin was applied for hemostasis. Intraoperative MRI confirmed total resection. The bone flap was restored and routine closure of the skin was carried out. Histopathology and molecular pathology confirmed diagnosis of anaplastic oligodendroglioma, IDH mutant. Thank you. In this video, we will present a case of a 41-year-old female who came to the clinic after experiencing intermittent seizure attacks of the right limbs for over 10 months. MRI scans revealed a tumor of the left cingulate gyrus. The lesion showed high signal intensity on T1 and T2 FLAIR images with contrast enhancement. 3D magnetic resonance spectroscopy analysis was done, and it suggested a high-grade glioma diagnosis. DTI tractography was done, and the language and motor pathways adjacent to the tumor were delineated. This multiple information aids in surgical planning and will be integrated for neuronavigation. The surgical plan was to perform awake craniotomy with cortical and subcortical mapping. The patient was laid in a supine position with the upper body elevated at 30 degrees. Following an arc incision, a tailed bone window was made close to the sagittal sinus to perform awake craniotomy with cortical and subcortical mapping. After dural opening, we use a monopolar probe to map the cortex for hand and foot regions separately. Following stimulation, a positive reaction is seen in the form of hand and foot movement. These cortical regions correspond to the respective motor regions. Using navigation, we locate the cingulate sulcus. These are the arachnoid granulations, so a little bleeding can be expected. Above the cingulate sulcus, we have the superior frontal gyrus, and beneath it is the cingulate gyrus. Bipolar cautery probes are used to make cortical incisions, which exposes the arachnoid and pia mater. Pathology and molecular analysis confirm the WHO grade 3 IDH mutant anaplastic astrocytoma diagnosis.
The last one is PCC.
In this
glioma.
video, we will
I
present a
prefer to
case of a
use the
70-year-old
transcortical
male who came
incision
to the
to
clinic after
expose the
experiencing
deep-seated
weakness of
tumor
left leg for 2 months. MRI showed a lesion on right posterior cingulate gyrus. He had no nausea or dizziness, but experienced continuous fatigue with no relief. A neurologic examination was normal and past medical history was not remarkable. MRI exams showed a lesion with clear circular enhancement in the right posterior cingulate gyrus. MRS showed a choline to acetyl N-acetyl ratio of 4, leading to a preliminary diagnosis of right high-grade glioma. DTI tractography was done, and the cingulum bundle and pyramidal tract adjacent to the tumor were delineated. 3D brain reconstruction enabled clear observation of all the eloquent subcortical fibers. This multiple information aids in surgical planning and will be integrated for neuronavigation. There are 2 choices for the shape of incision in transparietal approach surgeries. The patient was laid in a prone position with the head flexed. An MRI-compatible head frame was used for fixation and precision navigation registered. Following a U-shaped incision, a rectangular bone window was made close to the sagittal sinus. Strip electrode was laid on the surface of the brain. After dural opening, the postcentral gyrus, the precuneus lobe, and longitudinal fissure were located under navigation. The surgical plan was to resect the tumor through transprecuneus cortical approach with MEP electrophysiological monitoring. Incisions were made on precuneus lobe of the superior parietal lobe for transprecuneus cortical approach. The anterior boundary of the tumor was close to the postcentral gyrus. Therefore, unipolar stimulation was carried out, and the positive points of motor evoked potential were marked with P.
So for this case, the subcortical
Stimulation
motor
intensity
mapping
of
is
the
essential
unipolar probes
to
translates to a
preserve the motor
relationship of 1
pathway.
millimeter per 1 milliampere increase. At this point, the stimulation intensity was 5 milliamperes, indicating that the distance between the stimulated site and the corticospinal tract was about 5 millimeters. The cavity was cleared with warm saline and fluid gelatin applied to control bleeding. After dura closing, intraoperative MRI scanning confirmed a total resection of tumor. The parietal lobe and corpus callosum tumor infiltrated were resected according to the preoperative plan.
So you can see for
The
all
bone flap was restored and routine
those
closure
three
of the skin was
cases,
carried
gross
out.
total tumor resection was achieved.
Histopathology and molecular
no
pathology confirmed the
language and motor
diagnosis of
deficits
glioblastoma,
after
IDH wild
operation
type.
for all these
Thank you.
three cases. So among all cases, 95 patients, 87% achieved extent of tumor resection higher than 90%. And the percentage of extent of tumor resection of PCC group was the lowest in the 3 sub-region groups. In low-grade glioma cases, about 87% received extent of tumor resection higher than 90%. But in high-grade glioma, most of those cases are glioblastoma. Only about 50% received gross total tumor resection in accordance with renal procedure. And how about the functional outcomes? We assess the language function, motor function, as well as the cognition function. You can see MCC cases were significantly associated with short-term morbidity in either language or motor function. And the ACC cases, about 80%, escaped from any short-term deficit, and nearly 90% free from permanent morbidity. And these slides also show the outcomes, the functional outcomes in different subregions. The tumors in the dominant side, dominant hemisphere, that means the left side, was significantly associated with language dysfunction or cognition dysfunction, either short-term or long-term morbidity. And how about the overall survival analysis? Oh, sorry, for the morbidity, the predictor for the morbidity, for short-term morbidity, 3 predictor was proved to be significant, comprise age, subregion, and dominant hemisphere. But for long-term morbidity, only age is the predictor for deficits. And how about the results of overall survival analysis? The overall survival predicts tumor grade, IDH mutant, and the extent of tumor resection. So in conclusion, we believe that cingulate gyrus and the cingulum are near ring paralimbic structures on basis of 4 subregion models. Surgical approach and the surgical techniques are necessary to be planned. MCC gliomas are likely to suffer post-operative language and motor dysfunction in short term, but these dysfunctions could be relieved within 6 months. And the cingulate gyrus glioma in dominant side leads to language and cognition dysfunction more likely than that in non-dominant side, either short-term or long-term. And finally, the extent of tumor resection. For low grade, the threshold will be 90%. For high grade, the threshold will be 100% in accordance to the T1MR contrast image. Is still one of the essential prognostic factors of overall survival. That's all for my lectures. Thank you so much for your attention.
Well, thank you very much for a very excellent lecture. And again, one emphasizing the importance, the vital importance of anatomy. some lovely results and some wonderful philosophy involved there as well. So thank you very much indeed. So from the microscopic, I think, to the submicroscopic, finally in this session, we're joined from the University of Miami by Carolina Benjamin. And she's got the fascinating sounding topic of glioma management in the molecular age. I didn't know we were in the molecular age, but I'm enjoying it if we are. Thank you.
Let's see. Are you able to see my screen?
Not yet.
Not yet. Okay, let's try again.
That's it.
Beautiful. Hello, everybody. My name is Carolina Benjamin, and I'd like to thank everybody for Dr. Nasser, Dr. Jenkins, Dr. Borba for having me here today. I'm at the University of Miami here in Florida in the United States, and I'll be talking today a little bit about the glioma management in the molecular age. I have no relevant disclosures. So we just heard so many fantastic talks on anatomy and the critical importance of surgery in glioma care, which I think is undeniable. But it's just quite not enough. Unfortunately, regardless of how phenomenal of a surgeon we all may be, or the types of surgeries that patients get, we have to approach this disease from multiple areas. And so we've been, with new molecular data, we've been able to do that. And this has actually caused a shift. As we all know, the WHO grading scale prior to 2021 really was not the optimal method for the selection of the type as well as the intensity of treatment. And I think what the new WHO, the 5th edition, attempts to do is to sort of mitigate that as we get more information about molecular data. The subtypes are actually better indicators of tumor biology and therefore prognosis. And I think, like I mentioned, regardless of how phenomenal of a surgery you have, this has to be taken into consideration. So you can see here, this is an example of how the report is layered out now. So you get an integrated diagnosis that's based off of combined tissue histological data as well as molecular data. Then you get the histological diagnosis underneath that. You get a CNS WHO grade as well as the specific molecular mutation. And so here are just a few of these examples, of the different molecular data that we're looking at when I say that we're looking at these molecular markers. And this is pretty comprehensive, but really we've come a long way in this arena. So in the new classification scheme for gliomas, you can see here, it really sort of simplifies things to a degree. You no longer have, no longer have all the different subtypes, but you're really just dividing it into adult type, diffuse, and then pediatric. Pediatric is separated into diffuse low grade and diffuse high grade. And when we're talking about adult type diffuse, then it gets further separated or classified by the different, molecular markers, but it really sort of simplifies things to a degree. So in the old CNS classification, you would have 3 different tumor types: diffuse astrocytoma and anaplastic astrocytoma or glioblastoma. And now we're really sort of putting the molecular data up front, right? So you have in the CNS classification 5, you have IDH mutant, okay, and then you grade it based off of 2, 3, or 4. And then you have IDH wild type, and then based off of whether the presence of a TERT promoter mutation, EGFR gene amplification, or combined gain of chromosome 7 or loss of 10, that really determined that those are going to be your 3 highest grade WHO grades. So again, putting the molecular information up front, which is very different than previously. Now, what has allowed us to do this? Essentially, there have been major advances in the field of pathology that really have allowed us to get to this point, right? We're not only looking at the data, it doesn't take us two weeks to get this information. All of a sudden, in the past, we used to take out tumors and then we would send it off and then we'd be wondering whether or not, tissue is diagnostic. Nowadays, you're really getting this in real time. And this is some of Dan Oranger's work and with the Raman spectroscopy. And really, you're using AI and you're using this information real time in the operating room to get some diagnosis back. You have information about whether the tissue is diagnostic to the point where, a lot of places, including, I believe, Dan Oranger now is at NYU, they really have done away with frozen sections. And sometimes you can really rely on these to give you information in real time. Additionally, other groups here have also, Ganesh Shankar is also looking at this about not only getting information about what your tumor is while you're in the operating room, but in really 30, 40 minutes time, which some would say that in some institutions, that's how long the frozen section would take anyway. You're getting information about the molecular data at that time. So that this is really sort of, a very advanced approach to getting information pretty quickly. This is from, Dr. The Suba Lab in Boston, and this is really just looking at GBM as sort of an integrative model. It's sort of like 3 or 4 different RNA states, all right? And the different states actually are going to morph. They can morph from one state to another based off of therapeutic interventions. And I think the important thing about here is to realize that if these 3 states are present or 4 states are present, and you can actually morph from one state to another, then you can see why a single agent is going to fail. The glioma, gliomas are just too diverse to really base it off of just one approach. Again, looking at the past 10 years, and I'm going to shift gears a little bit to talk about immunotherapy because I think that becomes like very relevant here. But if you look at the past 10 years, we're really living in a revolution in terms of cancer therapy. In terms of FDA approval, we're really seeing an unprecedented numbers of indications that are approved as immunotherapy. And this is really the majority of the immunotherapies are based off of checkpoint modules or checkpoint inhibitors. So not to go too far into immunotherapy, but as we all know that for T cell activation to occur, you're going to have 2 signals, one with the antigen presentation and the other one that's either going to turn that T cell on or off to be active. And the cancers really have adopted this mechanism here on the right of T cell inhibition to really evade the immune system. So we all seen, evidence of, melanoma, kidney tumors, and really drastic regression in tumors in the past. And the drugs really act at this level, this inhibition level that I mentioned. And these drugs include like Opdivo, Keytruda, Imfinzi, and this has become really like a $25+ billion industry, and it's going to continue to do so. And it's acting, again, like I said, in that second signaling mechanism. All right. So again, this IO regimens, immune oncologic regimens have been really approved across the board for a large range of tumor types, right? And despite these major advances, there's still some limitations. Why? Because first off, the response rates are low. So the response rates for a lot of these immunological agents are sort of about 20–30%. Okay, there can be development of resistance in about 1/4 of the patients. And then toxicity remains a real challenge because people can get really severe side effects, pneumonitis, they get colitis, and they can actually die from some of these medications. So these are not benign treatments, and it's definitely an advancement forward, but it's not the whole story. So where are we in terms of checkpoint inhibition in gliomas in particular? So I think there's good preclinical data to suggest that these immune checkpoint inhibitors work. And this is some of Dr. Fetchi's work that showing that when you give an anti-CTLA4, and CTLA4 is a one of these checkpoint molecules, it does improve survival in mice. And I'm not going to go too far into the details of each of these because we're a little bit short on time, and it's sort of beyond the scope of this. But if you're interested, we can certainly talk more about that. But this is some of the data from Michael Lim's lab showing that a similar effect with the PD-1 blockade. Okay, and this was synergistic with SRS. So this is some of the data from Dr. Gerber showing that, and the ligand for PD-1 is called PD-L1, and it is expressed in GBM. And essentially, the higher grade gliomas, the more expressed PD-L1 is. So this led to a lot of trials looking at what the effect of inhibiting this PD-1 would be, right? So this was sort of, this was a large phase 3 clinical trial looking at anti-PD-1 for first-time recurrent GBMs. And this trial ended up being negative in the sense that it did not improve overall survival. And most of these, they do look at overall survival. Some of these trials that looked at progression-free survival is kind of tricky because when you're talking about immunotherapy, there's a lot of pseudo progression. So overall survival is sort of a better endpoint when we're looking at these. And this is a phase 3 trial looking at unmethylated MGMT, GBM, and PD1 inhibition. Again, negative results. Okay, and then this one's for MGMT, methylated newly diagnosed GBMs and PD-1 inhibition. And again, primary endpoint, overall survival. Really, at this point, they had not had enough data, but it turned out being a negative result, and progression-free survival, again, is not the best measure. So unlike, melanoma, renal cell, we haven't seen in GBM the same kind of responses that we would have hoped for, or sort of the results in terms of using immunotherapy. So why is that? I think, you got to think about hot versus cold tumors. So there's a spectrum of tumors based on their response to immune checkpoint inhibitors, and GBM sort of falls into the category of cold tumors, along with, pancreatic and others. And why is that? So why are these tumors not responding? I think you have to think about it like the 3 E's hypothesis. So essentially, there's in a lifetime of cancer, there's different interactions between the cancer and the immune system. And initially, there's an elimination phase where the cancers are going to be actively eliminated by the immune system, right? And then eventually, the cancers are going to acquire enough mutations to be in a state of equilibrium such that the immune system is able to remove as much cancer cells as are being formed, and you sort of have this equilibrium state. And then you have to acquire more mutations in order to escape. And and when it does escape, that implies that you have resistance. Now, you can think of resistance in 2 ways. There's intrinsic resistance, which is, mechanisms that the cancer itself has from the beginning, from the get-go, sort of these checkpoint molecules, right? And then you have adaptive resistance, which is that the cancers are going to develop resistance over time due to immunological pressure. And you can see that GBM is a really sort of tough dilemma, because it's up here, right, on the right-hand side, where it has high intrinsic resistance and high adaptive resistance. So this makes it a real problem. Different strategies we're working on to sort of address these resistant mechanisms. Talked a little bit about IO therapy. I'll talk a little bit more about these, some of these kindling approach, vaccines, CAR T therapy, and targeting this myeloid compartment. But these strategies, importantly, have to overcome both intrinsic and adaptive resistance. Okay. In terms of checkpoint inhibition, the PD-1 and CTL4 are not the full story. There are other ones, right? So we have LAG3, TIM3, in addition to PD-1, that are upregulated in glioblastomas, and that they become important. And we don't really know in terms of which one is more important than the other, but we do know that there is upregulation of these other checkpoint modules. And then there's this concept of exhaustion, which is essentially that you have, the T cells in 2 states. One of them, which is the effector state, and the other one where T cells lose their ability to sort of, and you don't see this interferon gamma production, so they lose their effector. So do they become terminally exhausted? Now the question is there a way for us to reverse that? Is there a way for us to change the immune modulator such that we can reverse this exhaustion and make T cells active, right? So is it an absolute, or can it be rescued? And you can see that the cells in GBM really do have this exhaustion concept. They don't express the interferon gamma. They don't go into that effector state. But, there are early trials of using PD-1 in addition with some of these other immune modules like LAG3 and CD137 to sort of reinactivate and sort of reverse this exhaustion state. All right, and then moving on a little bit to a kindling response. We all know in order to start a big fire, we got to start somewhere, right? And the kindling response is sort of this recruitment response, using all of our tools in our box. And one of these things is, stereotactic radiation, because as we know, radiation, when given in a focused fashion, can induce this kindling response. And it can do so, radiation can have its effect through direct induced cell death, or it can enhance the immunogenic cell death, right, through antigen presentation, cytokines, recruitment of anti-tumor cells. So these are all sort of ways that radiation can be used to work in our favor. I'll skip over this a bit since we're running out of time. And then chemotherapy. So use of local chemotherapy can also enhance immunotherapy. However, systemic chemotherapy is not going to do that. Systemic chemotherapy is really going to sort of put you in an immune compromised state, right? But we see through these trials that when given BCNU and PD-L1, there's a good synergistic response if it's given locally, right? So The other thing about systemic chemotherapy that's important to take into consideration, it also causes a change in the T cell, in the memory T cell. So it sort of changes your immune system and its ability to respond to things, right? So in a local setting, it can be useful, but systemically, it can become a little bit more dangerous. And then there's this concept of giving immunotherapy before surgery, right? And this is done by some of Tim Klowski's group. And when immunotherapy is given before surgery, patients tended to do better. And then what are they measuring here? In this study, they're measuring the actual ability of T cell clonality. So they're looking at the levels of T cell that are active, that are in that effector state. Okay. Other example of things that we're sort of using to our favor to, again, recruit this T cell function is laser ablation and focused ultrasound. And then just a quick few slides about vaccines. As we all know, the EGFR V3 vaccine trial came back negative, but we do have to, we are coming up with these personalized peptide vaccines, which is essentially, these vaccines work by you take the tumor out, right? And then you sequence the tumor, you run them through computer programs that are going to identify the antigens that could serve as vaccine targets. And then you're going to put it back in. So this is, Dr. Reardon is really showing an immune response mounted against different cancers based off of these personalized peptide vaccines, just another agent that we can sort of use to our favor. And this overall is going to, what we would like to do is to sort of enhance this myeloid compartment and use that to our favor. And one last thing that's sort of important that's an interesting thing, as we know, when it comes to brain tumors, they're a little bit different than the rest of the body, right? And it kind of, there's a systemic immunosuppression that occurs by virtue of having a brain tumor. That's important to know. It creates this immunocompromised state. And we've seen that proven in different ways. We've seen, different studies that have shown that lymphocytes are sequestered in the bone marrow. We've seen different studies that show that macrophages are going to, you're going to have increased peripheral circulating macrophages that are going to render these T cells inert. So we have evidence that is showing that this brain tumor, having the presence of a brain tumor, causes this global immunosuppression. And so a lot of these things that I've mentioned before are really ways to circumvent that. So in conclusion, I think initial immunotherapy results, unfortunately, have been disappointing. There's going to be high intrinsic and adaptive resistance in glioblastoma. And I think our current approaches are really combination approaches and sort of trying to target this known immunosuppression that occurs in the presence of brain tumors. Also, the glioblastoma microenvironment really are hostile to immune cells. So in order for us to create an environment in which we can sort of circumvent exhaustion and make those T cells active, we have to talk about the microenvironment as well. And you have to sort of be ready to anticipate early and late resistance to immunotherapy. I think future predictions of this precision type medicine, we've already seen that, people are looking at spinal fluid, in order to detect some of these, and use detection in the spinal fluid. And then even further along that, we're really going to the concept of the liquid biopsy and seeing if we can see some of these molecular markers in the blood to help us guide management earlier on and be very proactive. And that's it.
Well, thank you very much indeed, Carolina. That's, again, this typifies how different things are, how much things have changed in tumors in the last few years. Certainly when I was training, the treatment of a glioblastoma was you opened the head, put in a glass sucker and started ordering up the funeral drinks, but it's very, very different now. And let's hope that this continues and will be different in the future. Now we've got some questions and answers. I hope we've got some time. Have we, Nasser, is that okay?
Yes, of course. Jenkins, I can see many questions on the panel.
No, they're not showing up for me for some reason, the new ones. No, I've only got the questions from the last session here. How would I get the current ones? Why are they not showing up here? Have you got them, Nasser?
I'm trying to look at the chat too. Chat panel.
May I make a question here?
Yeah, go on, Luis.
First of all, I want to congratulate the session. You see, you need anatomy, neurophysiology, understand the approach, the whole complex. You see. But I want to make one question to Carolina. Today, the molecular biology give us a lot of information about prognosis. It's a few information about therapeutics. When you have this answer, when we change this paradigm, today we know that this guy is bad, the patient will die. This guy is not so bad, but the patient will die. When the information will come?
I mean, I think we've made advances. I think, again, like I said, in comparison to other tumor types, the brain has been a little bit disappointing in terms of the rapidity of actually getting to therapeutics. But I think we're, the first step is recognizing that there's a problem, and we've gotten there. So I think we have the correct markers, and I think it's just a matter of time about finding the right targets for those markers that we've now identified pretty clearly.
Gabriel, were you just waving generally, or were you wanting to speak? Gabriel Vargas?
Yes, just a similar question for Carolina. Is really the application right now of two things that you show, Raman technology, and how really you have confidence on that. And second question is, with all of those therapeutics that are developing, really what you see right now that is really changing the way of treating brain tumors, as for example with melanomas that change a lot with molecular biology, but I don't see for now today something that have that impact. What do you think?
I agree. I don't think there's anything that's had that impact. I mean, there are certain, cancers that, melanoma types that they're talking about, consider, and even lung cell types that they're considering cure, once people comes off, they become cured. And I don't think we're anywhere near that. I think there's also some promising work with dendritic vaccines. And I think vaccine therapy is an interesting concept for us. And then also this local, this local chemotherapy concept. I think it's just going to be a combination. The hard thing about this is that, a lot of these trials will throw in one or two or three things, and then you don't really know which one it is, right? And so that's another difficulty is sort of parsing out one particular thing. Is it a synergistic thing amongst different therapeutic agents, or is it just, which one is it? And I think that's really hard. And as you saw, it's interesting, a lot of the trials that I showed, all of them were sort of negative for glioblastoma. So that was a theme, right? Like we have not gotten there yet. And I think perhaps vaccines are going to get a little closer, but we're certainly not there yet.
Well, we've got to keep trying.
Yeah.
Now, the fact that there aren't any questions showing up in the question and answer section here leads me to the inescapable conclusion that there aren't any. And that's not a bad thing because we're running about 40 minutes late. So with that, thank you very much to all three speakers. Fantastic, fascinating talks, beautiful slides, and I'll hand you back to this. Thank you.
Thank you. Thank you very much, Jenkin, for moderating this excellent session. Thanks to all our speakers. Now I give the mic to the moderator of the third and last session, Azmi Elias, to take over. Azmi, are you here?
Yeah. Thank you. Sound check. Can you hear me?
Yes, it's very good.
Okay. Thank you very much, Professor Nasir, for your kind invitation. I think in the interest of time, we shall proceed to the third session of this special webinar on glioma from anatomy to molecular biology. So we will have 4 speakers, and each of them will be given around 15 minutes. And we will keep the question and answer at the end of the presentation. So it is my pleasure to introduce the first speaker, Professor Asil Ibrahim Sebes from Jordan. and she will be speaking about maximum safe resection of glioma. So Asil, welcome.
Thank you, everyone. I will start by sharing my screen. Can you see my screen?
Not yet.
Not yet. Okay. Now.
Still, I think still loading.
Okay, let's give it a minute.
Yep.
Technical issues are quite common.
Yeah, don't worry.
Okay. Okay, I'll start again. Can you see now my screen?
Yes, yes, very good.
Yeah. Beautiful.
Thank you. Okay, so hello everyone, and thank you for the great opportunity to be able to talk today. I would like to thank Professor El-Ghandour and Professor Borba for organizing this great event. And I must say that I had quite a lot of fun reading for this presentation today, because I felt like I am overseeing the advances that we're making to make our patients' lives easier, which made me feel like I am a part of something way bigger than myself. So I feel quite humbled. And I usually start by talking about my where I come from. So this is where I come from. I come from the Middle East, and I come from this twin states, Jordan and Palestine. This is where I come from. This is where I work. This is Farah Medical Campus in the capital of Amman, Jordan. These are a few pictures of my country. This is the capital, Amman. This is Jerash. This is Ajloun up in the north. This is our jewel, Petra, Dead Sea, and Wadi Rum. And these are photos of Palestine. This is Jerusalem. This is Jaffa. This is Ramallah. This is Jenin. And let's all pray for the peace of mankind everywhere. And I'll start with my presentation. It's about maximal safe resection of gliomas, and I will be talking about GBM per se. And I picked GBM because it's quite, it's obviously the most common and the most challenging to deal with. And I will start by saying that it's an ever-changing entity, and I'll explain why. So the WHO classification started in 1926, and not up until 1979 did we have a tumor classification for the brain tumors. So it started in 1979, and we have included here histological subtypes, and fast forwarding until 1993, we have introduced immunohistochemistry. In the 2000, we introduced genetic profiles. 2007, we had a combined pathology and a genetic consensus. 2016, we introduced molecular biology, and now in the 2021 classification, a lot of changes have been done, and as have the previous speakers before me have said extensively about this new classification. I will not be talking much about it, but there has been a lot of changes, and to say some of them, that it's a much simpler and more integrated one. The no longer not otherwise specified entity is no longer a category. GBM is now it's only the IDH wild type only, and it's always grade 4. And we have come to see that there are distinct characteristics of pediatrics versus adult tumors, and it had highlighted the importance of MGMT status as a prognostic factor. So let's talk about the extent of resection in GBM. Why is it important? Because after all of these studies, after all of these years, extent of resection is still the most important prognostic factor in progression-free survival and overall survival for our patients. But we often use the terms gross total resection, partial resection, supramarginal, and up until now, there's not a very, there's still some conflict as to which is which. So in general, a gross total resection is resection of all the contrast enhancing tumor on the post-operative images, and the supramaximal resection is beyond that, and we will talk and I will be talking about it later on. And there's a very it's very challenging dealing with eloquent versus non-eloquent areas, because in the non-eloquent areas you can go as far as doing a lobectomy, but in the eloquent areas we have we are quite limited with the area we are dealing with. We can talk about newly diagnosed versus recurrence of GBM, and there is quite some difference in how to approach an elderly patient with GBM versus a young patient. So also I should start, I should keep talking about the radiogenomics, which is a new entity, and it has a lot of role knowing the molecular thumbprint of the tumors beforehand, comparing images and histopathological databases, massive, extensive, that we can know beforehand what kind of tumor we are dealing with. And the supramaximal resection has been talked about a lot in the low-grade glioma, and now it's extending to include high-grade gliomas and GBM. And the more emphasis on the quality of life versus only overall survival. So the golden rule when it comes to GBM is surgery plus adjuvant chemoradiotherapy according to the STUMP regimen, but that had its own progress over time. So going back to 2011, we have this paper here, which has cited a previous paper that had concluded that if you cannot resect more than 98% of the tumor, you should not go, which gave the surgeons an all or none approach. And this paper came to talk about that you can have a significant overall survival benefit for the patients if you can extend more than 78% of the tumor, and that was a paradigm shift when it comes to dealing with GBM. And we all know that when you decrease the tumor burden, chemotherapy and radiotherapy work better. Going to 2016 here, and we have now gone to talking not only 78%, but even more. And it had defined that you can go maximum, you can achieve better outcome if you also resect the flare abnormality beyond the 100% contrast enhancing resection, which gives patient a clear benefit of survival. Going to 2020, now we have started to see that there are certain differences when it comes to elderly patients, and it had actually stated that there are some molecular differences when it comes to elderly patients having GBM versus young patients, but it had not talked about biopsy only and chemoradio. It's still talking about maximal safe resection for these patients. And now going to 2022, we're talking about supramarginal, and now we're talking about the extent of that. So anything less than 20% will not give the patient a clear overall survival benefit. Anything more than 60 does not add to it. So if we can stay between the 20 and 60% of supramarginal resection, we can add some benefit to the patient. And because we have extended the life expectancy of these patients as we go on and do more resection and more extensive surgery, we have now patients having recurrences of the GBM because it's the natural course of the disease. And this very interesting paper has been investigating the patterns of this in these patients. So it came up with 3 categories: local, marginal, and outfield recurrence of the tumor, which actually is only a marker for how long these patients are surviving post-operatively. So how to achieve maximal safe resection? It has been talked about throughout this day, but I will be summing it up. Anatomical knowledge is far and foremost the most important one. So we cannot be using only technology in this. I will go over the modalities one by one. So we can do a pre-op functional MRI, and I should maybe point out that it should be task-oriented. So we can correlate it with cortical and subcortical mapping intraoperatively. We can do a DTI, which gives us a spatial orientation of where the tumor is in comparison to the important pathways around it. Electrical cortical stimulation, we have talked about it, cortical, subcortical, and its importance. And we have this paper here talking about awake surgery plus cortical mapping and its clear added significance of achieving total and supramaximal resection of these patients. And actually it can go to predict the motor function 6 months post-operatively for these patients. Awake surgery, we have talked about it. It has a specific inclusion criteria. It has its benefits and its risks. Seizure is one of the most important concerns, but it does have a clear benefit, especially when it's added with, when it's combined with intraoperative MRI, especially when we are talking about complex anatomy like the insular area. 5-ALA has been used. It's rapidly taken up by the malignant tumors, orally administered. It has many side effects, but and it's also limited in the way that you can only see the tumor that is presenting to the tumor cavity that you are working with. So you cannot see beyond that. So that's one of the limitations of 5-ALA. And this is how you see it intraoperatively under the microscope. But again, it had shown clear benefit in using 5-ALA during surgery to achieve maximal safe resection in these tumors. And actually, the intensity of the light when you look through the microscope has been correlated with the degree of tumor and its aggressiveness. So these photos are from this paper. Intraoperative DTI, so you can use the DTI that you have done preoperatively, use it intraoperatively to orient yourself where you're working. And we have the contrast enhanced ultrasound, and it actually has shown clear benefit in obtaining a better resection for these tumors. So this is how it looks like intraoperatively, and compare it with normal ultrasound versus contrast enhanced ultrasound. And contrast enhanced ultrasound is actually one of the modes on the ultrasound machine itself. We can use intraoperative MRI. I think we can all expect it to be expensive. You need an MRI suite, you need MRI compatible instruments. There's a risk of infection, there's a risk moving the patient, there's longer hours. And but again, it has been shown that it adds benefit to the patient. When compared to 5-ALA, neither one of them had an advantage on the other, and they both were superior to conventional neuronavigation in achieving maximal resection. So illustrative case, I will be talking about butterfly GBM. And before we start talking about the case, we should define butterfly GBM. It's basically a GBM involving the frontal lobe and invading the corpus callosum, and it had been classically taught as it's the most aggressive form of GBM, but we will be talking about this later. So this is patterns of the invasion. It can invade the genu, it can invade the body, the splenium. And the concerns when it comes to butterfly GBM, that it had gained its bad reputation because maybe it had been falsely managed. Because when we talk about it, we tell the patients that you have the worst case, the worst kind of brain tumor, and you have the worst subtype of it. So classically, it had been done that you would diagnose this patient, you would have a tissue diagnosis via a biopsy, and then you would send them to chemoradiography. So had this worst prognosis been due to the natural course of the disease, or because we have failed to manage it? And so many surgeons fear the complications post-operatively of the butterfly GBM due to akinetic mutism, ebulia, deep thalamic nuclei injury, affecting the quality of life, and this needs to change. So we have this patient who is almost 60-year-old male patient from Iraq. He came with non-specific symptoms, headache, visual blurring. He had some abnormalities in his labs. He had hyponatremia, hypochloremia, and he was diabetic. We went on, we had these images clearly depicting poor margins, infiltrative tumor, areas of necrosis, which is very much likely a representative of a butterfly GBM invading the genu of the corpus callosum. So we did surgery. We don't do biopsy. We don't send the patient for chemoradiography. We do surgery with the aim of maximal safe resection. We did it under neuro navigation. That was back in 2017. And the histopathology came back as GBM grade 4. The patient woke up 15/15, no deficit. This is the post-operative MRI that we do immediately post-operative, the next day. No waiting. We can see that all of the tumor, or all of the contrast enhancing parts of the tumor were taken out. And we had given our patient his best chance when he takes the chemoradiotherapy afterwards. And this paper had been talking about the extent of resection when it comes to butterfly GBM. And because most surgeons would fear taking the part involving the corpus callosum, and because of the post-operative deficits that we have talked about, they have refrained from surgery. But this paper beautifully states that the extent of the callosal component, extent of resection of the callosal component does not impact survival, and we should go on and take as at least 65% of the tumor, because only biopsy gives the patient an overall survival of 4.2 months. And we should keep in mind KPS age and the molecular profile of the tumor does play a role in its prognosis. So take home messages: glioma, its molecular biology, its genetics is changing, so stay updated. Extent of resection is still the main factor determining overall survival, including butterfly GBM. Gross total resection plus chemoradiography is the mainstay. We should use the peer-reviewed technology as a routine. Supramaximal resection for better overall survival should be studied more intensively before accepting it as a standard of care. And biopsy and chemoradiation should be stopped. With this, I finish. Thank you, and I hope I did not exceed my time limit.
Thank you, Asil, for such excellent presentation and for keeping in time. So she covered an overview of tumor classification, the evolution, and emphasized on the importance of to achieve maximum tumor resection to reduce the burden of the tumor so that it will enhance the adjuvant treatment. And she also shows several cases, difficult cases, especially in managing butterfly glioma. So we shall proceed with the next presentation, which is from Nader Sanai from USA. And is Nader here?
Yeah, I'm here. Can you hear me?
Okay, thank you very much. So he's going to talk about tissue-based clinical trial for glioma. So please welcome Nader.
Well, thanks very much. Thank you to the organizers. This has been a really fascinating seminar to watch. I'm here in Phoenix, Arizona at the Barrow Neurological Institute, and I've enjoyed some of the speakers. Clearly, we have many masters and experts here in the panel and on the schedule. And many of the talks have focused on the surgical aspects of brain tumor treatment, and then more recently on some of the molecular diagnostics. What I'm going to try to do is pivot a little bit towards what I see as the neurosurgeon's role in what happens to patients after surgery, which I think we can all agree is in many ways far more disappointing than what happens in the operating room. We have all become very adept over the course of generations at resecting these tumors safely. The problem, of course, is that after all of our hard work and efforts and the patient's recovery, the tumor then undoes all of our progress because of the lack of adjuvant therapies that can hold it at bay. So I'm going to make 4 points during this brief talk. The first is that there's nothing I'm describing here that's new to neurosurgery. There have been generations before us that have already forayed into what we call surgical trialing or tissue-based trialing in support of drug development. So this is a space that I hope many of the young neurosurgeons in the audience will consider seriously as undertaking as part of their clinical and academic practices. The second point I would make is that drug development today and in the recent history has really missed the biological context for which it's supposed to be treating. We rely upon animal modeling and artificial scenarios to guide us in developing drugs, but in fact, we should be relying upon our patients and their particular tumors. The third is that there is obviously a large drug development industry internationally with biotechs and pharmaceuticals, but their efforts are often guided by us and by our colleagues. And it's up to us to advocate for promising agents to be accelerated, but equally for unpromising agents to be abandoned. And finally, I'll give you some examples of how we need to be a little bit more creative in trial designs so that the entire spectrum of potential therapeutic options beyond surgery become available to our patients. So I mentioned this history we already have in our field of surgical trialing, and here are just 6 of many neurosurgeons who in the recent past have really engaged drug development and new therapeutic development through the operating room. And for each of these studies that I've listed, we've gained incredible knowledge and identified promising and unpromising agents simply through testing them in the operating room and using that tissue as the basis for the strategic development. I'll start by just reintroducing or introducing for some of you some of the terminology that we need to be familiar with as neurosurgeons and neurosurgical oncologists. The first is the concept of a window of opportunity study design. So one of the previous speakers, I think Dr. Benjamin, alluded to one study with this type of study design. This is the concept where a new drug is introduced to the patient for days or weeks with the intent of treating the tumor, having a therapeutic intent, as we say. And then after a period of time, the patient goes to our operating room, tumor is resected, and 2 types of categories of tests are performed on a tumor. Tumor pharmacokinetics, which is the measure of drug concentrations, and tumor pharmacodynamics. And then after the operation, the patient continues on this therapeutic treatment until tumor progresses. So this is called a window of opportunity study design, in contrast to a phase 0 study design, where it's very similar. However, the drug is introduced to the patient without therapeutic intent. And once the patient goes to the operating room, that study is over. The drug no longer is given to the patient. So these are 2 sides of the spectrum, and I'll give you an example of each. This is a study of neoadjuvant nivolumab, a checkpoint inhibitor, as we heard about, where the patients received the drug before surgery for several weeks, and then the tumor was tested to see if there was immune response. And following that, they went back on the drug. So they have therapeutic intent, an operation, and then continued drug dosing. This is the first phase 0 study that was ever performed in 2009 at the National Cancer Institute. And this is with a PARP inhibitor, where the patient simply got a single dose of the drug the day before surgery, went on to surgery, and had their tumor pharmacokinetics and pharmacodynamics tested. So these two strategies are bookends on a spectrum of strategies, and there's a lot of overlap between the two. But what's very clear in our field, which this publication recently highlighted, is that there simply have not been enough of these types of studies done by us in the last 50 years. And there are 4 challenges here. The first is technical, which is that we all know the operating room is a complicated environment. And so to incorporate these types of tests requires some logistical help. The second is operational, which means that the laboratory efforts for these types of programs have to be integrated with the operating room. And that's why neurosurgeons, such as you, need to be at the epicenter of this integration. The third is, of course, access to new drugs. And I would state that new drugs for these types of programs are available when you demonstrate the ability to pursue the program. And finally, the fourth is accrual, because some of these studies are non-therapeutic, as I mentioned, and that's not appealing to patients. Now, Lisa DeAngelis, who's a neuro-oncologist at Sloan Kettering, I think said it best when she said that we rely too much on trying to resurrect what are clearly negative studies. And we see this year after year, negative large-scale trials then be reanalyzed in order to find some thread of positivity, when in fact, we should simply just assess them as negative and move on. So this is what's called failing fast, where patients are given the drug, we go to surgery, we make the analysis, and then if it's not working, we move on. At our center at the Barrow, we have a research program called the Ivy Brain Tumor Center, where we focus on a modified version of this phase 0 concept. This is, as I've shown you, the typical phase 0 trial concept, and it has 3 limitations in terms of the ethics of giving a patient with a malignant glioma a drug, but not intending to treat them with the drug afterwards, questions of efficacy, questions of the durability of the treatment are all unanswered. So our approach has been to genetically screen patients, match them to some sort of new drug device, drug cocktail, administer that experimental therapeutic prior to surgery, and then ask one of 3 questions at the time of surgery. Did the drug get in? Did it hit its target? Or did it do both? And these questions are answered. And on the basis of that answer, that patient may then go on to expanded therapeutic dosing with that experimental therapy. So these triggers, as we call them, basically identify patients that are responding to the drug and then fast track them into a formal or informal therapeutic study design. I'll give you an example. Here's a drug cocktail under investigation. It's a CDK4/6 inhibitor, which is a cell cycle regulator targeting agent, and an ERK1/2 inhibitor, both from the company Eli Lilly. This is not a study that the company pays for, but it's something that we do through grant support. The patients are screened after recurrence, after they've had standard of care, STUP, complete resection, and on the basis of their genetics, they're given 6 days of this drug combination. 6 days is not enough to cause significant side effects in a patient, but it is enough to then measure the concentrations of both drugs in the patient's tumor. And then on the basis of that, if there's sufficient drug to have confidence that the drugs can work, the patients then go on to a formal phase 2 study design. So this is the kind of data that you get from this type of clinical trial. Every column here is a patient, and the red bars indicate the total amount of unbound drug, meaning the free non-protein binded drug in the patient's non-enhancing glioma. And anything above the dotted red line indicates the patient has sufficient amounts of this drug. This is abemaciclib, the CDK4/6 inhibitor. And you can see that overall it performs fairly well, although there are a handful of patients that don't acquire enough drug in their tumors. And this is important for us to understand the heterogeneity of patient response to drugs. This is the second drug in this cocktail, where there's even more patients that don't respond and a handful of patients that do. So it's only patients that have sufficient drug for both of the cocktail elements that go on to get therapeutically dosed. And then we can not only see how they do clinically, but we can look at their tumor genetics and ask what's happening in these patients if they're not having a durable response to this tumor. Because we know the drug is sufficient in quantity in these patients. We can see that the drug is hitting its target, so something else must be happening. And this is the kind of clarity that we need in drug development, rather than just simply putting patients on trials on faith and looking at survival curves and saying this doesn't work. I'll give you another example of this type of strategy, and it's around radiation, which I think we can all recognize as one of the more effective modalities we currently have worldwide for patients. In fact, it's the single most accessible modality for treatment worldwide. But the challenge with radiation is that there are many different mechanisms through which radiation can be circumvented. So here we have a clinical trial using what's called a PARP inhibitor. This is in not only recurrent patients, but also in newly diagnosed patients. So patients who are unmethylated at MGMT will be put on this trial at initial diagnosis, get the drug before surgery, and then go on to have an operation. And if there is sufficient drug, and in this trial, we compared one PARP inhibitor, pamiparib, to another PARP inhibitor, olaparib, those patients go on to therapeutic dosing, and they go on to therapeutic dosing in combination with radiation. So here you have a drug that's targeting something related to radiation response, but you're not so interested in just what the drug is doing, but rather what is the synergy between the drug and radiation? So the way we can answer that question from the operating room is by excising that tumor tissue, taking it to the laboratory and cutting it in half, and half of it gets radiated, half of it doesn't. The entire tumor has been exposed to drug. And this gives you an idea of what is the synergy of the radiation with the drug effects. A final example I'll give you is a drug device combination. So this is a strategy called sonodynamic therapy, which basically involves a patient getting 5-ALA and then having non-invasive ultrasound delivered several hours after the 5-ALA is metabolized to protoporphyrin 9. And that convergence of the ultrasound energy and the metabolite protoporphyrin 9 leads to cell death through a series of reactive oxygen species formations. So patients have the drug, they have the targeted ultrasound, they have a timed operation, and then we excise the tumor in a supratotal fashion. Why supratotal? Because we need to have a complete serial reconstruction of the tumor from start to finish, from anterior to posterior, in order to understand the effects of the therapy. Because in this trial, only half the tumor is treated with the ultrasound and the other half is not. So every patient is their internal control. So this allows you to then serially section and analyze the entirety of the tumor from front to back, looking at the control regions, comparing them to the experimental regions. So here is a study design where there is no question whether this patient's tumor is or is not having a response, because there is no external control or randomized placebo. This is simply the patient's own tumor compared against itself. So I'll just conclude for our audience that, as a reminder, surgical trialing is not new, but as neurosurgeons, we can lead and advance its applications within brain tumor drug development, and that should very much be a focus of our efforts in the years to come. there is urgency to doing this quickly, identifying agents that are promising and de-identifying agents that are not. We've seen from some of the talks today how exceptional we've become in surgically treating these tumors. And we've also heard comments as to the lack of promise as to what happens after surgery. And that's where we need to step in. And these trials need to be expanded to represent the entire ecosystem of therapeutic modalities that we see and have at our disposal, whether it's drug device combinations, drug trials, radiation sensitizers, etc. So I think I'm out of time. I will thank all of my colleagues at our center here at the Ivy Center. Thank you and the organizers for the opportunity to speak today.
Thank you, Nader, for very insightful lecture. I learned a lot from this lecture. You cover a little bit on the flow of a clinical trial and the challenges that you face, especially involving new drugs and using a brain tumor tissue-based trials. So we will keep the question and answer at the end of the session. So for the time being, we shall move to the third presentation. So it will be from Dorota Lubenska from Canada. So the topic will be, yeah, you are there, very good. So the topic will be heterogeneity of brain tumor initiating cells as an emerging target for novel therapeutic strategies against glioblastoma. So Lubenska, please welcome.
Can everybody see my presentation?
Yes, perfect.
So first of all, I'd like to thank organizers for inviting me here to speak on the forum of this webinar. What a fascinating morning this has been for me. I'm actually really happy that I joined since the beginning, and I get to see some of the clinical insight into GBM. And my presentation will be a little bit different than what we've seen today. I'm going to bring you all more closer to the lab and basic biology that our lab does on brain tumor initiating cells of glioblastoma. So we all know the statistics. Glioblastoma accounts for more than 200,000 cases a year worldwide. And we know what the treatments are. This has been covered here today extensively, but what is more important about the GBM is that its high rate of recurrence and 15-month median survival are really terrifying statistics. 5-year survival rate is of less than 10%. So among other things, these statistics are attributed to the high level of genetic and phenotypic heterogeneity of GBM. And glioblastoma, as other types of cancers, is a dynamic disease. And during the course of this disease, cancers generally become more heterogeneous. As a result of this heterogeneity, the bulk tumor might include diverse collections of cells harboring distant molecular signatures with differential levels of sensitivity to different treatments. And this heterogeneity might result in the non-uniform distribution of genetically distinct tumor cell subpopulations across and within the disease site. So we're talking here about the uneven distribution of cancer subclones in the primary tumor, so within the tumor bulk, as well as in the metastatic size, and that's what we call spatial heterogeneity. Or we are talking about the temporal variations in the molecular makeup of a single lesion over time. This is either as a result of natural progression of the tumor or as a result of exposure to selective pressures created by clinical interventions. And this is a temporal heterogeneity. So the different colors in here, as you can see, they denote the presence of subclones with different genetic features. And this heterogeneity in response to therapy and to treatment results from those genetic, transcriptomic, epigenetic, and phenotypic changes to the entire bulk of tumor. And one of the best examples of such heterogeneity is glioblastoma. And this heterogeneity over the years right now has been widely studied and attributed to the presence of so-called brain tumor initiating cells. And we know that those brain tumor initiating cells are very rare populations of cancer and brain cancer cells that exist within the tumor bulk. They have stem-like character and very high level of plasticity. They are responsible for disease initiation, recurrence, and therapeutic resistance. So as you can see in here, this is just a cartoon depicting what's happening. So after apparently successful therapy, we have those cells remaining behind. They are resistant. They can cause tumor regrowth and, of course, patient relapse. So in here, I input some of the therapeutic strategies targeting brain tumor initiating cells that have been described in literature extensively over past, let's say, 10 years. But what we have to understand is that to be able to properly targeting those brain tumor initiating cells, we have to have a really good understanding of what those cells are. So their identification and characterization. We're talking here about the molecular mechanisms that are driving those cells, their survival and proliferation. What are the markers that we can identify them by? How is the tumor microenvironment supporting growth of those cells? And what are the mechanisms that they are developing to resist the applied therapies and their immunoevasion? So that's what we do in Porter Lab, and the general consensus is to walk away from the highly propagated in cell culture cell lines. They've been in cell culture for years, and they kind of lost this life relevance. So we as other labs right now are collaborating with local hospitals as well as hospitals here across the border in Detroit. We obtain tissues from consenting patients and we extract cells from those tissues. Those cells are then cultured in the conditions that are supporting brain tumor initiating cell characteristics. And actually we biobank those cultures in our lab. Those cultures then undergo very strict evaluation using PDX mouse models and evaluation on their genetic level. So we are able to subclass them into the main types of GBM and study them accordingly. So another thing that our lab is really focusing on is what are the markers that we can characterize those cells by, and we are actually focusing on three main markers that are very well described in the literature and very well established. Some of them are there are poor prognosis markers in patients, and the utilization of those markers allow us actually to have those cells extracted from the heterogeneous cultures of the patient tumor and study them in the life cells, in their life state. So study basically their functions. And because the time is limited today, I'm just going to focus on one of the markers that we have some results on, and I'll show you how we utilize and how cancer biology lab can utilize markers, study it to kind of point towards some potential therapeutic interventions in patients. So CD44 receptor is it's a tumor initiating cell marker. It's actually a poor prognostic marker for patients with GBM. It's a transmembrane glycoprotein and its ligand is hyaluronic acid. So when hyaluronic acid binds to CD44, then it stimulates the downstream signaling of the receptor, which will lead basically to cell growth, survival, and processes like migration and invasion, which will contribute to further glioblastoma progression. And what we know from the studies in our lab right now, we are using two main models. So we are using a brain tumor organoid model and a zebrafish patient-derived xenografts. And you can see in here, this is just an example, and this is just, those are cultures derived from individual patient in here where we treat those patients in those two different systems with a panel of drugs that are utilized in clinic. You can see that the patient with the low expression of CD44 receptor respond over time in the organoid system to two of the drugs applied, which in this case is temozolomide and one of the EGFR inhibitors, whereas the patient, in comparison to the patient with the high CD44 expression, we do not see this response. And this is mirrored in our in vivo system. When you can see when we inject the cells into the zebrafish embryos, we grow them over time. You can see that over time we have with the temozolomide again and this EGFR inhibitor, we see the decrease in the foci formation in the patient who has low level of CD44 expression in comparison to the patient who has high levels of CD44. We do not see basically almost no response to any of the drugs applied. So what we came up here at the University of Windsor with our colleagues from the chemistry department, we generated this nanoparticle system, which is based on the conjugated polymers. And those nanoparticles are coated with hyaluronic acid. As I mentioned, that's a ligand for CD44 receptors. So we are here aiming towards selective targeting of those CD44 positive cells. This hyaluronic acid is labeled with fluorescence, so we can easily track the nanoparticles either in vivo and in vitro and further study them. The system is actually very flexible. We can code it with other moieties and target other populations that we study in the lab in our patient cultures. And we can also encapsulate available therapeutics into the system. So first of all, what we wanted to know when we started working with this system, we wanted to know if it indeed selectively targets those CD44 positive cells. So at the beginning, we just used the U251mg commercially available cell line just to look what we get. And you can see in here that we cultured those cells with the treatment of those HACPNs, so those our nanoparticles, with different concentrations, increasing concentrations. You can see in here that after the treatment, we stained them with CD44 antibody and ran them through flow cytometry. So you can see that the cells which are positive for CD44, the black bars here, have significantly higher uptake of the nanoparticles in the comparisons to the negative cells. This is just in vitro, but it shows that selectivity of those particles towards the CD44 positive cells. And we confirmed this in our patient culture. So you can see in here that in 4 out of 5 patient culture tested, we see this selective uptake of those nanoparticles in CD44 positive cells versus the negative CD44 cells. So then we were kind of curious how those cells can affect the proliferation of the GBM cells. So we ran the proliferation assay. This is just the trypan blue exclusion assay when you look at the cells viable versus non-viable over time. And in 2 out of 3 patient cultures in here, we saw significant decrease in the cell proliferation when we were treating those cells with those nanoparticles in comparison to the control. And this was consistent with the decrease in the viability, average decrease in viability in those cultures. We also examined stemness effects on the stemness of this nanoparticle system using neurosphere formation assay. So this assay is indicative of the self-renewal and stemness characteristics of the culture. So we know the more stemness we have, the more aggressive population of brain tumor initiating cells we are dealing with. So when we treated the patient samples, this is based on 3 cultures, we treated them with those nanoparticles. We see that in 2 generations of the spheres, we have a decreased number of the spheres being created by those cells. And this is consistent with the decreased diameter of those spheres, which is indicative of the decreased self-renewal potential in those cell lines. And looking at the gene expression levels, we found that the treatment with the HACPNs decreased proliferation and stemness markers in comparison to the vehicle control. And that was consistent with increasing levels of differentiation when we were treating them with the nanoparticles in comparison to the control. And we also saw decreased mRNA levels of pro-survival markers in those cultures. Because CD44 plays a huge role in tumor invasion and migration of GBM cells, we tested those effects upon the exposure to the nanoparticles. And here we actually tested CD44 positive cells, which were enriched for our nanoparticle system, or the ones which were lacking the uptake of the nanoparticles. And you can see in here that this is after 72 hours, the cells containing the nanoparticles, they were migrating significantly less than the cells which were having no nanoparticles. Then we tested this in the patient culture. So we embedded those neurospheres that I just showed you in the previous slide into a matrix. So we are basically looking at the invasion into the matrix that mimics the brain substrate in our in vitro system. So you can see in here that this is graphed over time of 6 days, that already at day 3, we see significant decrease of the invasion of those patient cell lines into the matrix in comparison to the spheres just treated with the control. And we've noticed that there were a bunch of cells that were migrating as single cells into the matrix. So we scored those as well. They're a little bit faster progressing than the actual forefront of the sphere in here. And on average, we see that over the 6 days, we have decreased in the number of those single cells migrating when we treat the cells with HACPNs in comparison to the control. And this is consistent with much shorter distance that those cells were migrating for. So of course, as a cancer molecular biology lab, we were interested how are those nanoparticles exerting their effects. And this is just a very basic part of our study that I want to show you here. We know that when we treat the patient cultures with our nanoparticles, what we see by flow cytometry is that we significantly decrease the levels of those highly stem-like tumor initiating cells that are positive for both CD44 and CD133. But we are actually enriching for those cells which don't have the tumor initiating cells characteristics. So this is very good result, and that will be a good prognosis for the patient. So then we looked at the protein levels of CD44 in those samples treated with the HACPNs, and we basically found that the treatment with the HACPNs significantly decreased the protein levels of the CD44, as well as the protein levels of the intracellular domain, which is indicative of the activity of the receptor. This is quantified over here just to show the significance of this decrease. So then further in the patient samples, just running them, treating them with the nanoparticles and running them through flow cytometry, we indeed see the decrease in those tumor initiating cells that are positive for CD44 receptor in those patient cultures, which is very exciting. Then we, of course, wanted to move to the more in vivo setting. And prior we reach any mouse model, we evaluate usually our compounds that we test in a zebrafish model. So this is zebrafish embryo at 48 hours post fertilization. So we were testing here blood-brain barrier impermeabilization by the nanoparticles that we're testing. There in the yolk sac of the zebrafish embryo is injected with nanoparticles, and you can see here by 5 and 8 hours, those nanoparticles are already readily migrating to the head area of the zebrafish embryo, and they stay there significantly upregulated up to 14 days post injection. So of course, we wanted to know how now those nanoparticles could affect the growth of the tumor in that in vivo system of our zebrafish. So we first injected just U251 cells, which are negative for CD44 receptor versus the cells which are positive for CD44 receptor. You can see this is quantified here, the tumor burden at 5 days post-injection. The tumor burden of the foci that were generated by the CD44 positive cells is significantly downregulated, but that is not the case for the CD44 negative cells. So we are basically confirming here that selectivity of those nanoparticles in vivo. And of course, then we moved to our patient-derived xenografts. In zebrafish, we use multiple patient cultures for this. This is just here an example of one of the patients to show you how this tumor spreads in the zebrafish over the 6 days post-injection. You can see that we treat the zebrafish with the HACPNs, we see significant decrease in this heterogeneous populations of the patient cultures in comparison to the control. And this in here is under evaluation of the tumor burden in CD44 positive cells derived from the patient's average treated with the nanoparticles we have. Although we see still growth of the tumor, we see significantly decreased tumor growth in comparison to the control. And just to quickly show you something which is more therapeutic in here is that this is, of course, an in vitro study, but what we see in our lab is that when we were treating our cultures with dinaciclib, which is CDK inhibitor, we see selection for the CD44 receptor. So then we were thinking, maybe if we can select for this receptor and hit it with something which is selective for it, we would be seeing much more of the cell viability. So we picked some cell lines which are resistant to temozolomide. Some of the patient cultures that we know are resistant. You can see in here that the response, the viability of the cells treated with temozolomide is actually the highest from all of the treatments. But as soon as we start adding the HACPNs, we see this decrease in the glioma viability with the highest decrease observed when we have the triple treatment with temozolomide, dinaciclib, and HACPNs. So this was, I just showed you the study today just to give an example how a basic cancer molecular biology lab contributes to further progress in the treatment of GBM and fighting that feared disease, where today we're just looking at the molecular mechanism, some of the, how we can use the cell surface markers and then hit at those pathways that are regulating survival, proliferation of those cells, and generate a nanoparticle system, which is selective for some of the therapy-resistant populations. And with that, I would like to thank our primary investigator of the lab, Dr. Lisa Porter, for her continuous support and allowing us to do those amazing studies in the lab. And majority of those experiments were done by my students, Sami Al-Rashed, Alexander Sorge, Fatima Ladim, and Alex Rojinka. I want to thank the rest of the lab, of course, our collaborators, neurosurgeons, without whom we would not be able to perform those studies. Thank you very much for listening to me.
Thank you, Dorota Lubenská. I think very interesting presentation and topic. So she described very well how you can use these brain tissue cells that you can culture and use the biobank and different surface markers that can be used to utilize and looking at the potential therapeutic function. So we will keep the question to the last. I think we shall move to the last presentation. That will be from Professor Yu Yao, and he will talk about MRI pharmacokinetic of contrast enhanced delivery in brain tumor. So do we have a Professor Yao here? Professor Yao, can you unmute? You have to unmute.
Can you hear me?
Okay, very clear.
Okay. Thank you, Professor Azmi, and thank you the invitation from Professor Naza. It's my honor to present here, and I'm from Hua-San Hospital. My topic name is MRI pharmacokinetics of convection enhancement delivered in the brain. As we know, the glioma is the most common primary malignant brain tumor. Standard protocol for glioma, including surgical resection and adjuvant radiotherapy and adjuvant chemotherapy, such as temozolomide. And we also use tumor treating field in China. For temozolomide, only about 20% can go into the brain, cross the blood-brain barrier, cross the BBB. So it's very little percent to go into the brain. As we know, there are at least three ways to overcome the BBB. The first one is the control release system, such like Gliomas. It has an advantage like cross BBB and release slowly over the prolonged period of time, but also has some disadvantage, such like limited drug loading capacity and poor drug distribution, complications such as seizure and edema. The other way is nanomaterial system, and it will have a high surface to volume ratio and promote diffuse through the BBB, but also have some poor control accumulation and distribution. The third way is focused ultrasound, and it is uninvasive and low system exposure, but it will also cause edema and uncontrolled thermal injury. For if the lesion is located here, in the parenchymal site. There are three ways. If we use neurosurgical skill to intravesicular infusion the drugs or the intercellular injection the drugs, they will go into the brain, but they will cause another barrier named CSF-ISF barrier. And there are also a target problem, such as only 20% temozolomide will go into to the brain, but they will not surely to go into the tumor side. So the third way is the CAD technique. He can go directly to the lesion. For example, what means the convection? If the infusion site is here, then diffusion will get a large range. But if they caused by a pump, they will get a much longer range. This means convection. For the present in the 2020 SNO, we know that for the recurrent glioma, this is temozolomide for 5.4 months. This is Gliomas, this is TTF, this is lomustine, this is Avastin plus lomustine. But if you use the CD technique, target IL-4, they will get much longer overall survival. But in general, for a clinical trial, phase 1 means you should get the PK and the PD and the MTD of the drug. So if the drug going to cross the BBB going to the brain, we need to know the concentration. We need to know pharmacokinetic of the drug in the brain. But in fact, it is hard to do so. So if we use the CED compartment, it can consist of 3 parts, including intraluminal catheter, connecting tube, and infusion pump. It will cross the BBB and get the large volume of distribution and the low system exposure. But recently, we do not have lack of pharmacolytics and local concentration study, and also lack of ultramicroscopic study. And if the drug going to the brain, they will take the risk of ventricular leakage. So for this famous 3 clinical trial, they target IL-3, but they have difference between the Gliomas. So I think they will lack of the pharmacology of this target trial. So we use T1 mapping, use the MATLAB progress. We change from the T1, transfer the signal intensity to the T1 relaxation time. Use this equalization. If we know the concentration, we know the relaxation time, then we can calculate the drug's relaxivity. This is the procedure to relaxivity, to the gargling, and the CD infusion, and the distribution parameter, and the scan in the hydrogel protein, and determine the gliomas. We use the different concentration of gliomas, then can to the T1 scan, and get the T1 mapping, and get to the concentration mapping. We use this equation, finally we found for the relaxivity for gliomas is 3.9. And this is a result in the hydrogel protein. The VD means value of distribution calculated by the equation of fluorine and chrome. And VI means value of infusion displayed by the micro infusion pump. And the T-molar and depends of gliomas concentration in hydrogel. This is a different time over different time. And we found in the center of the infusion site, and compares with the periphery site, we found that when the time pass on, the ferry time site will increase and the central time will decrease. As shows this picture, in the center site, infusion site, time after the infusion, the center of the drug will decrease and the 6 million from the center will increase. Now, how about the real time in the rat brain? Then we use the CD infused from the base MRI scan, then MRI scan, then image registration and the volume of distribution, and then use MATLAB to calculate the concentration. As shown here, and this is a column, this is sagittal, and this is horizontal, and we contrast the image after gadolinium. There are three rat brain, and all the brain, the VD, VS, VI is more than 4. And here is the detail of the scan image pre and post pre-infusion and post infusion, different time, 0, 20, and 40, and 60 minutes. We use T1 scan to transfer the T1 mapping, then transfer the concentration mapping to calculate the concentration. We found that the center will decrease after time, and the ferry will increase. And this is the rat 2, and this is the rat 3. And how about the drug if they go into the brain and go into the periphyseal, if they leakage to the ventricular, what will happen then? Then we set up the animal model. This is pre-infusion, and this is pre-infusion T2. And post-infusion, we use CED catalytic to place it into the ventricular. Then if in the non-living state for rat 1, we can find the gadolinium will always in the ventricular, because due to the absence of metabolism. But if in the living state, interventricular administration, the gadolinium is mainly distributed in the subarachnoid space, did not enter to the brain parenchyma. So the pharmacokinetic of intraventricular CED infusion in the living state, we found after 30 minutes, after 1 hour, there will no drug in the ventricular. They will go into the subarachnoid space. So our study development as method of determining the drug concentration in the CED study based on the MRI T1 mapping. This is a preliminary proof of concept study, shows pharmacology of characteristic of CED in the hydroplane and in the rat brain. And the gadolinium relaxivity in vitro to be determined, and accuracy of concentration determined is also verified. Misplace of catheter to the catheter or leakage of infused. And the next time we will go to the temozolomide and ultra microscopic study. We can see a very preliminary study about ultra microscopic study. This is a control group, and this is infused. We found increased fluid content in the cytoplasm, but there is no significant damage to the organism. And this is a control. And for the infused group, there is no swelling of snapshot cleft and very little loosen of myelinated flap. So that means the CED will not damage the fiber tracking or the DTI. So thank you for your attending.
Thank you very much, Professor Yao Yu. So for a very interesting presentation. Now I would like to invite all speakers to be online again. Can you put on your video or camera on? So I would like to probably look at the question from the chat box. I think there is one question, even though it's already answered, but probably I would like Nadir to answer. I think one question from Anna. So could you please say if there are multi-center trials for GBM treatment that our patient could be involved? Hopefully this information can be also shared by all other audience in case they are interested to involve in the trial. So Nadir?
Thank you. Yeah. So in short, multi-center trials are fairly common. Our group has several of them and many other groups across the world do. I think it's really important that as a community, we band together in multi-center fashion to get some of these studies done. Oftentimes this happens in the context of a consortium, although consortia can be large and unwieldy, sometimes very inefficient. So our preference is really to go through smaller, informal multi-center groups where it's really a collection of colleagues working together at centers across a single country or multiple countries. I think I responded to that particular question by just encouraging anyone who's interested to just email me directly if you're interested in studies that we're performing, or email investigators at other centers if you're interested in their studies to see what specifically is available.
Perhaps others speaker also probably runs a multi-center trial in their center, probably Lubinska as well as Professor Yao Yu. So if you like to share the information to the audience. Okay, if Dorota is still online, because there's one, I think, question for her. And from Martin, I think Woodley. So what is the nanoparticle?
So, so nanoparticle is part of the nanosystems or nanotechnology that been over the years developed in different treatments for different diseases, not only for cancer, but it's particularly important for cancer. Those are basically small derived particles. They're on the nanoscale, like the name points. So they would be at the size of around between 80 to 100 nanometers. They could be made up of several different materials. So in our case, is that conjugated polymers. But there are a bunch of other like gold particles. There could be aluminum particles. Different materials are being used. And important things about it is that you know, if they are the size of this 80 nanometers, which basically puts them into category of the nanotechnology, they are able to pass the blood-brain barrier, which is important in the treatment of GBM.
Okay, thank you very much. So there is one question I think posted around 11:30. What your view about autologous vaccine for glioblastoma multiforme given after standard care? So is any one of the speakers can answer that question?
Well, I can give a general response, which is that I think the field still awaits some positive evidence at a level 1 level, at a randomized level, in support of the strategy. We recently seen, I think just a few weeks ago, the data from the DC Vax trial, which is led by Linda Liao and Northwest Biotherapeutics, where they shared what may be interpreted as positive data in a randomized phase 3. The caveat being that they use an external control rather than a placebo. So I think we're getting closer to that reality, and immunotherapy in general obviously is a very hot topic, but so far we haven't seen an autologous or non-autologous vaccine that's definitively effective yet.
Okay, thank you very much. So we have another question from Martin. So what is the incidence of severe reaction of T-cell promoter activator stroke inhibitor monoclonal antibodies treatment? So perhaps Ade Lubinska or Nadir, can you answer that question?
I cannot.
Okay. May I ask something to Nader?
Sure.
Yeah, please.
First, since say that looks like now the glioma is in the oncology world more than neurosurgical world. It really will change the treatment in the future of the DBM. I'm sure that, I don't know how long, but the answer will come. And you are the guy that is driving this. Congratulations for outstanding work. And can you share some preliminary results of your trial 0? What's your feeling if this trial today? You are feeling comfortable with what do you think? Just between you and me, okay? Don't need to tell anybody.
Yeah, of course. Well, thank you, Luis. I mean, look, I think that if you look at our field in neurosurgery, clearly we're capable of doing more than operating, and operations are critical and still the most effective therapy. But we need to be part of the solution in all domains. We have surgeon scientists and investigators that for years have been trying to understand the basic biology of cancer and brain cancer, but we need to now pivot into more applicational efforts where we're developing the therapies. I don't think that we should just wait for our colleagues in neuro-oncology to answer those questions, and frankly, they need our help. To answer your question, Luis, you know, our sense of where the solutions lie for brain tumors is that number one, the concept of a single drug or even a couple drugs or a single therapy like a vaccine being effective and durable for something as shifty as glioblastoma just does not add up. We have to be pushing into combinations of 3, 4, 5 drugs, and you don't see that today. So we have to adapt our strategies in order to do that. The other part of it is that, as we all know, and as some of the speakers spoke about today, this tumor is a moving target. When we operated on it the first time and the second time, those are not even the same diseases. So there's so much adaptability that we have to have the ability to track that. Right now, what happens is we understand this tumor at just single points of time. We resect the tumor, that version of it goes to the laboratory, that version of it goes to profiling. But in that same patient, 2 months later, it's a different version. So we have to have the ability to kind of continue to move and adapt the therapies as the tumor adapts. It can't be a single solution or a single cocktail.
Thank you. We hope.
I think we almost overshoot about 50 minutes. I pass over back to Prof. Nasir. So I think we had an excellent session, at least for the third session and the first and second as well. So back to Prof. Nasir.
Thank you. Thank you. Before I close the session, I invite my friend Luis Borba, if he likes to give any closing remarks.
First of all, I want to thank all the participants, more than 400 people here on Zoom. Don't know, Professor Nasser, the Chinese channel, the WeChat, was online with thousands of people watching there.
Really?
Soon we will share the link of this program. This webinar should be seen again. And now we're going to the right direction. Soon you have the answer. I don't know what is soon, years, I don't know, but we still have a hope. And we as a neurosurgeon, we are changing the way to see the GBM and the glioma. This to be the great difference, I think, in the future. Thank you all the participants. Thank you all the professor. Professor Nasser, always you are brilliant. You are doing a great job. You keep working together. Next month will be vascular. No, you talk about microsurgery, talk about neurosurgery. You try to keep the real neurosurgery that you did real alive. Thank you very, very much, all of you.
Thank you.
Next time.
Thank you, Lewis. And I would like to thank all our distinguished speakers and moderators. Remind all of you that our next webinar number 62, it takes place after 2 weeks, Friday, 10th June. It will be collaboration with Professor Andrew Reisner. He is chairman of the Neurotraumatology Committee, Professor Robiano, Laura Lipa, and Franco Servadier. And then we will have another opportunity to work with Professor Luis Borba about vascular and aneurysms. And it will be 4 weeks from now, and we will announce about it. Thanks to all our distinguished speakers and moderators. It was an excellent symposium. May I not forget to thank the organizing team and Mr. Ahmed Magdi for all the great job they are doing in this series of webinars. Thank you very much, and see you again soon. Thank you.
Thank
Thanks,
you.
Nasser.
Bye-bye. Thank you. Take care. Bye-bye.
Thank you.
you.